call the meeting to order. Agenda item number 1 is the approval of minutes. Included in your packets are a copy of the minutes from the May 19th meeting of the Commission. If there are no changes or corrections, I'll entertain a motion to approve. Second? Any discussion? All in favor? Aye. Any opposed? Minutes are approved. I'd like next to introduce 2 new commissioners. First is Dr. Jerry O'Connor, who is a surgeon in private practice in Chestertown, Maryland. In addition to his private practice, Dr. O'Connor has served as the chief of the medical staff and chief of surgery at Chester River Hospital Center, which is now the University of Maryland Shore Medical Center at Chestertown. Dr. O'Connor received his undergrad medical education at Georgetown University and completed a residency in general surgery at George Washington University as well. Dr. O'Connor will bring a perspective to the Commission of a physician that is serving a rural Maryland community. Welcome. Our second new commissioner is Ms. Cassandra Tomarchio, who's currently the Business Operations Manager for the Enterprise Information Systems Directorate at the U.S. Army Communications Electronics Command at the Aberdeen Proving Ground. Prior to her employment with the U.S. Army, Ms. Tomarchio has held several positions in public affairs, including as Director of Communications for Coventry Healthcare of Delaware. She has a BA from Ursinus College and has completed additional study at Johns Hopkins and at the College of Notre Dame. Welcome. Commissioners, you've received the written updates from our centers. Ben, do you have any additional updates to share with the Commission?
Thank you, Mr. Chairman. On behalf of the staff, I'd like to welcome both of our new commissioners. I'd note that Dr. O'Connor already has his first assignment. We'll leave that for him to explain at a future meeting, but we will certainly look forward to both of your service to the Commission. I also wanted to handle an administrative matter that the September meeting of the Maryland Healthcare Commission will be held on Tuesday, September 20th. We're moving it to accommodate several commissioner conflicts in September. We anticipate that we will have a morning meeting retreat of the Commission, followed by the monthly meeting beginning at 2 o'clock. Please pay attention to our website for the formal notice, but again, the meeting will be moved from the preceding Thursday to September 20th, the following Tuesday. A couple points of note. As you know, Senate Bill 707 was passed. We'll be considering the Rural Health Delivery Work Group today, but the work group that has been operating for some time to develop a state health plan for freestanding medical facilities will resume its work on June 22nd at 10 o'clock in the morning in this office. We will be looking at proposed regulatory changes that we will add to this draft state health plan to accommodate the framework for a acute care hospital converting to a freestanding medical facility. So we have added some additional members reflecting the additional scope of the freestanding medical facility state health plan chapter. Members of the public are, of course, welcome. 2 other activities of note. Last month, I talked about our work with the Patient-Centered Outcome Research Institute. We, in collaboration with Lorien Health, CRISP, and the University of Maryland, submitted a $4.7 million proposal to PCORI in early June. Our role would be to handle the data quality and consumer engagement aspects of the grant should we be awarded. PCORI is extremely competitive in its awards, so we'll wait and see what the outcome is. As you know, this particular solicitation focused on innovations, and we were offering a comparative analysis of a traditional community-based team intervention for patients discharged from skilled nursing facilities in comparison to a telehealth-based intervention. The focus being how these two interventions stacked up in terms of patient outcome and satisfaction. Secondly, the Commission has been, over the last month, very heavily engaged with health plans and managed care organizations that operate as part of Medicare in trying to encourage those plans to submit a proposal to the Centers for Medicare and Medicaid Services for a new federal initiative on advanced primary care called the Comprehensive Primary Care Plus program. Obviously, if there's a plus in front of it, there was something that preceded it, and that was a previous demonstration, Comprehensive Primary Care, which I'll now refer to as the CLASSIC program. The CLASSIC program was launched in 7 regions of the country, was judged to be reasonably successful. In April, CMS signaled its intent to expand the program up to 20 regions around the country, engaging 5,000 community practices. The Maryland and our partners, including payers, but also the Medicaid administration and HSCRC, worked with payers here in the state to try to encourage them to submit applications, because the first step in qualifying for this demonstration is demonstrating that you have sufficient private carrier and MCO participation to warrant CMS's commitment that Medicare would participate. I'm happy to report that our largest commercial payer, CareFirst Blue Cross Blue Shield, and Anthem Amerigroup, our largest MCO, both submitted applications. Our goal was to get 50% penetration in both the private market, which we definitely succeeded in achieving through CareFirst participation. We didn't quite do that with Medicare, Medicaid MCOs. Amerigroup represents about 27% of the market share in managed Medicaid. But we're hopeful that those 2 applicants would be sufficient to garner attention from CMS and would allow them to make an award to Maryland, in which case the next step would be that CMS would seek private practice participation to participate in the initiative. The CPC evaluations to date have been reasonably promising. They haven't quite achieved an overall ROI on the project, but they have showed some significant success, particularly in Oklahoma. And they were judged sufficient for CMS to move forward with this program. Significantly, and there are 2 different tracks, which if commissioners are interested, I will provide that later. Both of those tracks are compliant with the new initiative that was enacted last year under MACRA, which provides advanced payment models for providers and additional advanced incentive payments for those participating. There are only 5 Medicare models that meet those advanced payment model requirements today, and so I'm very enthusiastic and hopeful that the program will be awarded to Maryland, in which case a significant number of Maryland primary care practices could participate and therefore move into an advanced payment model, which is something that CMS has signaled they are very committed to doing. Lastly, I also wanted to note that we're moving forward with our continuing medical education initiative with our colleagues in Missouri. As I noted last month, Dr. Andy Pollack is working with staff on that, and we look forward in July to showcasing some of the work that's being planned on this initiative that will focus on educating or informing primary care physicians on appropriate use of advanced imaging. Without any questions?
Any additional center updates? None? Okay, let's move to agenda item number 3, Kevin McDonald, Chief of Certificate of Need, will present staff's recommendations regarding a CON application filed by Kaiser Permanente South Baltimore Medical Center to expand its ambulatory surgery facility to add a third operating room. Kevin.
Thank you and good afternoon. The applicant today is the Kaiser Foundation Health Plan of the Mid-Atlantic States. They established the Kaiser Permanente South Baltimore County Medical Center in Halethorpe in 2013 after receiving CON approval in 2010. The medical center offers a range of primary care and specialty care services, as well as ancillaries. In addition to the current two ORs that are on site. This application is to expand the facility by one operating room. When the application was approved in 2010, space was allowed and built for shelf space for a third OR, and so this application is to come back and finish off that space. The cost of the project is about $1.6 million, and it will be paid for out of cash reserves. Looking at some of the key standards in our state health plan and how the project comports with those, the charity care requirement calls upon an applicant to provide at least as much charity care as the average ambulatory surgery center in the state, which at the moment is 0.46%. In this situation, the charity care is not provided specifically in the ORs at the center, but more broadly by Kaiser. And they do this through providing financial assistance to reduce the barriers to care and coverage by subsidizing, working with other public bodies to recruit and help pay for insurance coverage for people that can't afford it. So it's done more at the corporate level than it is not done at the site level, but at the corporate level in this case. But it does exceed our requirement. In terms of the need standard, the state health plan requires an applicant to show a credible projected need for OR use that reaches at least optimal utilization. Optimal utilization is calculated as 80% of the 2040 annual hours that are available. Those 2040 annual hours are arrived at by 8 hours, by assuming an operation at 8 hours a day for at least 255 days a year. In 2015, Kaiser's current ORs were in use for an average of over 2,400 hours. And for 2016, in terms of the projection, it will grow above that level. So the usage as of 2015 already justified the 3 rooms. The projections that Kaiser has made for its growth is tied to the growth of their membership base, and that grew by 42% between 2013 and 2015. And if their projections for 2016 pan out, it will grow another 21%. So the need for this room is not in question. In terms of looking at consideration of cost-effective alternatives, the applicant did consider an alternative that might in fact prove more cost-effective in the long run, and that is adding more space in addition to this shelved space, but made the judgment that the time involved in a bigger project at this point in time would create too much of a delay to complete this OR, which they feel a very strong and immediate need for now. In terms of viability and financial feasibility, again, the project will be paid for out of cash reserves. Operating expenses of the center are not dependent on the surgery volumes there, but are subsidized out of plan operations. Again, this is a staff model HMO, which provides the services directly to their members. Staff did note in the report that the Kaiser Foundation Health Plan of the Mid-Atlantic states showed a cumulative loss of $31 million over 2013 and 2014. When they were asked about that, they presented a plan that would turn a strategic plan that looks at turning that around by increasing their membership and gradually reducing its rate of expense growth over time. They also reported that there has been a significant increase in membership in line with that strategic plan and financial turnaround. They do have a track record on previous CONs. They have, in 2010, they received CONs for 2 other facilities, one in Largo, one in Gaithersburg, and there were conditions on each of those CONs that they would obtain accreditation from JCHO or the Association for Ambulatory Healthcare within 18 months of operation, and also execute a transfer agreement that meets the requirements of DHMH regulations. And in all 3 cases, they complied with those conditions. This project will not have really any impact on any other providers, as it is being used exclusively by Kaiser members. In summary, the staff analysis is that the relevant state health plan standards have been met, as have the criteria in our COMAR 10-2401, and staff would recommend approval of this project. With us today from the applicant are Andy Solberg, their CON consultant, Cheryl Rockford, who is a senior planning consultant, Heidi Jones-Huffman, who is one of the architects on the project, and Tammy Calagaro, who is the director of the Surgery Center.
Thank you. Can I get a motion to approve the certificate of need? Second. Any questions or discussion? All right, seeing none. All in favor? Aye. Any opposed? CON is approved. Move to agenda item number 4, which is the approval of the Rural Health Work Group members. Erin Dorian, Chief of Government and Public Affairs, will present the plans for the Rural Health Work Group and ask the Commission to approve the chairs and membership. While Erin is coming up here, I want to recognize Senator Stephen Hershey. Senator Hershey represents Kent and Caroline County, and he was a sponsor of SB 707 and will serve on the proposed work group. Erin?
Thank you, Mr. Chairman. Excuse me. Get set up here. Before I get started, I wanted to let you know what to expect for my presentation. I'm going to do a quick reminder of how we got here with a brief overview of Senate Bill 707 and its purpose. I'm going to also do a quick overview of the charge of the work group, and then I'll review what staff has been working on since session has ended, and our work plan for moving forward with this very monumental task. So just as a reminder, SB 707, Freestanding Medical Facilities, Certificate of Needs, Rates, and Definition. In the codified section of the legislation, it requires MHCC to establish regulations for freestanding medical facility conversions. The regulations must address public notification, and the regulations are being incorporated into the current draft of the FMF chapter of the State Health Plan. That work is being done by Paul and Eileen Fleck, and it's currently in motion. In the uncodified section, recognizing during the process of working out the legislation, there was recognition of the challenges in delivering health care in rural communities, and the General Assembly included language requiring MHCC to form a work group and oversee a study of the healthcare system in the Mid-Shore region. These 5 counties include Queen Anne's, Kent, Dorchester, Caroline, and Talbot. The legislation requires some members on the work group, including 6 General Assembly members and 2 chairs of the health committees, the Secretary of DHMH, the CEOs of several rural hospitals, and then other stakeholders, including providers, consumers, local government, business, and labor. The purpose is to examine the challenges for delivering health care in the Mid-Shore region, review policy. The work group is to review policy options under the study, and the work group is to make recommendations to the General Assembly for approaches on effectively meeting the health care needs in rural communities generally. So I see the study and the work group as a symbiotic process. They inform each other. Just to review the study is to be conducted by an entity with expertise in rural health. Again, examine the challenges in healthcare delivery in the 5-county Mid-Shore region. Examine the economic impact of closure of a hospital or conversion. Identify opportunities created by telehealth and the Maryland all-payer model and any other innovative care models that the Commission might think up. Develop policy options for addressing the healthcare needs in the 5-county region, but also with a broader eye on rural areas, and identify approaches for applying policy options to other rural areas of Maryland. So, what have we been doing since session ended? The legislation includes funding required for the study for over 2 years. So we've been working with DBM to get that funding source transferred to us. We are currently working on an MOU with the University of Maryland School of Public Health. The University of Maryland School of Public Health plans on collaborating with one of the HRSA Rural Health Centers. Right now, they are in talks with the Nork Walsh Center for Rural Health out of the University of North Dakota. So our work plan for the work group and the study. So between now and July, we are going to finalize the MOU and meet with the chairs should they be approved today. We hope to have a Rural Health Summit out in the 5 counties in late July or early August. We plan to have approximately 5 meetings every 2 months between September 2016 and September 2017. Those meetings will toggle between the Eastern Shore and Annapolis as needed. We're also required to hold 3 public hearings, which we plan to do in the fall of 2016, and the final report will be submitted to the Commission in September 2017 to be delivered to the General Assembly by October of 2017. So in front of you, what we're asking you to approve today, you have 2 documents. They look like this. The first one is a list of the 30 members chosen for the Rural Health Work Group. We received approximately 75 names, so we worked very diligently to try to have membership that's broadly inclusive, that has members from the 5-county region as well as members with a statewide perspective. We tried to get providers, we tried to get business, we tried to get consumers, we tried to get stakeholders with many different perspectives. The first 9 names are the names of individuals that are required by legislation. Senator Hershey, Senator Mathias, Delegate Sample Hughes, and Delegate Jay Jacobs were appointed by General Assembly leadership. The next document you have are brief bios of the recommended chairs. Ms. Deborah Mazier is a resident of Kent County, but she has an extensive background in health policy. She worked in health policy for many years, including working on Capitol Hill. And Dr. Joseph Ciotola is the health officer for Queen Anne's County and the medical director of Queen Anne's County Department of Emergency Services. He has lived and worked in the region and also has an interesting perspective on the healthcare system. With that, I'm here to answer any questions or listen to your discussion and take notes.
Terrific. We'll start here and then go clockwise.
I just have a quick question about the slide. I just want to make sure I understand this. So the 3 public hearings would be in the fall of 2016?
Yes.
So the meetings start in the fall of 2016, so the public hearings would happen when the meetings start as opposed to later or spread out?
So we would start the public hearing process in the fall of 2016. The public hearings really should inform the study, so we want to start them as soon as possible. We would have the meeting of the work group first. When I say fall, I'm talking more about November, December, but we'll do them before session really gets into gear because things kind of go a little sideways during session. And we really want to have them done before next spring. So they'll probably be, hopefully, November, December, but if we have them to a little later, that's what we'll do.
Maureen first.
Thank you. I have a question about how the interface is going to take place between this process and the rest of the rural areas of the state. You touched upon it, and I read it, and I noticed there's one Western Maryland representative on the committee. But could you just fill that in a little? How is the rest of rural Maryland going to be represented here and or have input, if at all?
So, to be honest, the study really is supposed to focus on the Eastern Shore, and the outcomes are aimed to be applicable to the rest of rural Maryland or rural areas in general. The CEO of Garrett Regional Medical Center was added by the sponsors in an amendment to include some of some input from other rural areas, and also Lara Wilson, the executive director of the Maryland Rural Health Association, is on the work group to sort of lend that broader statewide perspective. But really, the work group at the end, the recommendations are supposed to aim to create a set of best practices.
Right. And I guess my concern is just, how can we have any confidence that whatever the differences might be in the western part of the state and their rural health needs are going to be addressed and are going to dovetail nicely. I'm just expressing that concern. Perhaps sure. The panel would take care to study that.
Sure, and we will talk with the chairs, should they be approved, about trying to make sure that some of those concerns are heard. It's going to. I think that the sponsors understood that a large study of all rural areas would just not be as feasible at this point, because there are, like you said, there are many different challenges for a rural area such as Western Maryland that will differ from the Eastern Shore. So I don't think that there was any, they weren't just ignoring those challenges, but the idea is to try to have at least some broad best practices that can be applied. And there may be a need to study other rural areas in the future.
Thank you.
Maybe the Senator, would you like to comment on that at all? Sure. When we come up? Sure.
Well, first of all, thank you very much for asking me to come up, and I also want to publicly thank the Executive Director, Ben, and Aaron as well for helping us through this legislation in the last session. I learned a lot about freestanding medical facilities much earlier than session started, and I have to admit I was not in favor of them to begin with. But we did a lot of work during session. We worked with the Maryland Hospital Association on kind of what this new facility would look like. And as you see, by the end of the session, I had put my name on as a co-sponsor. And I'm very proud of the work group that will come out of this. The delivery of healthcare services in rural areas is very important to us. And I think what we were looking at while we were talking about freestanding medical facilities and where we are with the new waiver is that possibly a one size doesn't fit all in Maryland. and the way that healthcare facilities are looked at in the urban and suburban areas where travel time and access doesn't seem to be the same as what we're looking at in Maryland. And obviously, we were looking at the potential closure of a hospital in Chestertown, and that's what got us to be in the position where we thought that this work group will allow us to really take a look at how healthcare services are delivered. To answer a little bit of your question on why this area focused on these 5 counties, it's also related to the way that the structure is set up, with University of Maryland Medical System controlling a number of facilities within that 5-county region. And then that 5-county region is now Shore Regional Health. So we wanted to make sure that we were looking at an area, a rural area, that had that component to it. So where we would see what it looked like from a bigger, broader company looking at and controlling that. And McCready was brought in because of, again, it being a rural hospital, but it didn't have that same component, and Western Maryland did not also. So as Erin said, and she's absolutely correct, that we thought if we looked at this too broadly, we wouldn't probably be able to get to some of the concerns and the detail that we wanted to. But at the same time, we are hoping that this becomes a model, and Chairman Mac Middleton, one of the things that he's really excited about with this is that he hopes that as other states come on and take on the waiver, that Maryland could have done this study or will have done this study, and that possibly the results of this study could be looked at by other states as well too, as they look at the challenges of the waiver and how they deliver healthcare services to both urban and rural settings. So that was the reason for that.
I'll keep going this way. Bob?
Can I just on the same point, or are you moving on to another?
No, I have another question.
Oh, okay.
Another observation.
Yeah, I guess I would just say that I totally understand the need for a focus to get this done. I think in my own thinking, I would just be very open in a year or so. The folks from Western Maryland said, could we have something that looked at our particular problems and not say, oh no, that train left the station with this particular study. Just in terms of just when we think of Appalachia versus the Eastern Shore, that it's not going to be, I mean, it's great that this one will try and make as many generalizable recommendations as it can, and that's to be lauded. But I guess, you needed to be able to answer his questions specific to that kind of, it's a 5-county area that we're talking about. So you should do that. I guess I'm just going to keep basically myself a very open mind if the Western Maryland guys wanted to come later and say, could we look at specific problems that we suffer and distances and mountains and different things like that.
And I don't think we were trying to avoid any of that. And again, that's why, as you said, the amendment was put in place to add the CEO from Garrett as well too, to make sure that we throughout this process are gaining that the thoughts and the conditions that are out there as well too.
No, I'm very strongly supportive of this effort. I'm very familiar with Kent County. I think there's another element to this that the Commission should be aware of, and that is the Eastern Shore. Dr. O'Connor knows more about this than I do, but the Eastern Shore has been changing over the past many years, and what we're noticing is that there's a tremendous growth in retiree communities over there. More and more of the patient base, for example, of the hospital in Chestertown, more and more are people over the age of 65. So one of the values of this exercise will be to see how we can best serve the needs of a very demanding patient population, an older patient population. And as you know, Mr. Chairman, right now, I mean, we are in the midst of a chronic illness crisis in the United States, and it's primarily related to the growth of things like diabetes and cardiac problems and cancer and things of that sort. So this is a very, very worthwhile effort, and I'm very, very happy that we're actually doing this. And I think with regard to Commissioner O'Grady's point, we're going to learn a lot from this study, but we'll also, that will in fact have a great deal of value for folks in Western Maryland. The demographics are not exactly the same, but nevertheless, if Western Maryland wants to have a rural health study, I think this commission would be certainly supportive of that, I would hope.
Any
I do. Yes. Yeah, thank you. And thank you, Senator and Aaron, for the work to get us to this point. I have an observation that it appears that the trigger for this very important work really had to do with facility, the future of specific facilities on the Eastern Shore. But I guess I want to mention the obvious, which is that rural health goes beyond facilities and really gets into a lot of either the shortage or not the shortage of community-based providers. And so I would hope that the scope of the study is as broad to include primary care, but also to include workforce such as dental providers, such as behavioral health counselors, to really look at the population needs and how that aligns with what the workforce capacity is. So you did mention telemedicine, I guess, in the study outline, which is, I think some states have used telemedicine as a partial solution to that workforce shortage, but I would just hope that the study is comprehensive beyond the facility walls to really look at the entire population health needs. Thank you.
Thanks. I had a question. I think it's probably more for Aaron. How did we settle on 30 as the right number for the work group? It just seems like a lot of people.
So I really wanted 20, but when 9 are required by legislation, and we have 75 names of people that come in, my arm was twisted. So we felt that this group it includes a broad enough group of stakeholders without being too overwhelming. The work group that we did last year to look at the Maryland patient referral law was about 22 people, and so this one exceeds that one. But we did feel that we needed more members to at least include all of the stakeholders that wanted to be represented. We're also including 4 ex officio members, Ben, Dr. Kevin Seaman, the head of MIMS, Mark Luckner, the executive director of the Community Health Resources Commission, and Donna Kinzer, the executive director at HSCRC. We've added them as ex officio members, so no state bureaucrats would really be kind of counted towards the total, but that they could also be represented. They just won't be voting members.
Thanks. And then one more. How is this work group being supported? Do we have any outside consultants coming in to work with them? Is it mostly going to be handled by our staff?
So it's the University of Maryland School of Public Health through the MOU will support the efforts of the work group. They're not just going to be doing the study. And then our staff, and we have staff from DHMH.
Thanks.
Yeah. I think it's important to note that we did discuss at a very early stage with the University of Maryland in College Park the need to bring in some of the HRSA rural health research centers, and we're looking to do that with the Walsh Center and potentially others. There's each of the rural health centers has a different or somewhat focused area of expertise, and as opportunities arise, we may use others as well. But certainly the University of Maryland did a pretty strong study on researching on the health needs of Prince George's County, and they are well positioned to take this on in collaboration with the Rural Health Research Center.
I hate to throw a wrench in this whole process here on my first day on the job, and the great work that you did and everyone else to contribute to this, but let me start off by throwing this shocker at here. I strongly object to Dr. Ciafolo being on this committee either as a chairman or as a member. Let me give you a reason why. Going back to November 2015, Shore Regional had some consultants come in, and their recommendation was to close inpatient care at my facility, Jets River Hospital. I was privy to this information because I was invited to listen to this concept. the CEO of Shore Regional, Mr. Kozel, and I have objections to him being on it also, proceeded to tell the members of our hospital facility, nurses, and all the other workers, don't worry, there'll be no changes here. At the same time, they petitioned for a CON to change it to a freestanding medical facility, and since there were none available at the time, they tried to fast-track it by introducing a bill. If it's tied to an acute care hospital, you could do it without a CON. I listened to this long enough, and I guess I just couldn't stand any longer, and I initiated a movement. And with all due respect, I think this whole work group came out of this movement. Let me try to explain. I got about 12 people together from Chestertown, notable members of the town, business, schools, retirement villages. By the way, Chestertown's been ranked #1 retirement town in the state of Maryland. Anyway, got these people together and got this motion moving. We had a major meeting at the local firehouse. Senator Hershey was present. And he took that energy with him, and from that, and I haven't seen written anyway the amendment to 707, which protects a specific hospital in Kent County. They don't even mention us by name, but from being converted to a CON until 2020. Dr. Ciafolo was on the board of Chester River. He does not live in the county. He was appointed by UMS to be on our local board, yet he was not, and I was at multiple meetings with him, and I found him quite confrontational, not knowledgeable about health care in my county. Now he sits on the board of Shore Regional and has stated on the record that he thought that our intensive care unit should be closed, for the record. I don't think he can give an unbiased opinion being a chairman of this study group, nor can Mr. Kozel, because Mr. Kozel and myself, we had major difference of opinion. And this whole study came about because of the campaign we started in Kent County. I think Senator Hershey will agree with that. I'm disappointed in the representation from Kent County. Yes, we do have 4 members, great members, but there's no quote-unquote physicians in the trenches. Margaret Malero, great physician, but I believe she's in Centerville, not quite what I would call rural Maryland. There's none of us from Kent County who deal in the trenches and understand all the difficulties of delivering health care in rural Maryland. So I'd have to object to Dr. Ciafolo being on this study, and I would even consider having Mr. Kozel removed from it. Thank you.
Other questions or comments from the group?
One, and it is, I had the same concern about the size. And I understand the constraints you're under. And so it would just be a suggestion of one, because I have way more experience with this kind of stuff than I ever wanted to, as both staffing earlier in my career and then being members of them later. And the model I would suggest for next time, if you find yourself under this, is I sat on a Medicaid commission, 2006 or so, and they had 2 levels. There were sort of, it was a large one, like a 30, but there were like 12 to 15 who could vote, and then the others had, and so where you had something, especially where there was a lot of different interests who wanted a seat at the table, they got to certainly speak as much as the voting members did and everything else. But when the final votes came down and you had to strike those compromises of what would be in the report and what wouldn't, 12 to 15 was just much more manageable. And it allowed representation without kind of getting unwieldy. So if you find yourself in this position again, which I have a hunch you very well may, I was surprised. I didn't think that the people who were on the non-voting members, I thought they would revolt, and I was wrong. It worked fairly well. That this was each little disease group who was being served by Medicaid, wanted their guy there, and there was pressure to do that. But they didn't get a vote on the final report and the final recommendations. So
we could cut it by 2 right now, Dr. O'Grady.
I understand.
So for for the new commissioners, one principle I've always had is to have healthy conversation and frank conversations. And I want to take your feedback and just see if any other commissioners have questions to you or want to sort of discuss that feedback.
Yeah.
Any comments?
Mine is more of a comment than a question, and in some ways it's drawing on what Commissioner Phillips was saying, and also what Commissioner O'Connor was just saying as well. And I expressed this to Ben as we were talking about the potential makeup of this group. And like Commissioner O'Grady, I've been involved in a number of groups like this, and ultimately we want people to trust the outcome of the work. I mean, it's a lot of work, and you really want people to have faith in the outcome of the work. And so when I was at the National Quality Forum, for example, we would literally lay out what are the perspectives that we want to make sure are represented in the group, and start with that, and then plug folks in. Also thinking about who would be trusted in the community and who might be, in some ways, too close to the issue, particularly if there's particular business interests, or, I mean, we all have perspectives. We all have our own biases that we bring to the table. But I was struck by Commissioner Phillips' comment around thinking about this in terms of, this is about what's right for the community and what's right for ensuring the health and the health care is available appropriately within the rural area in the context of the waiver, and in the context of the innovation that's needed, and in the context of the changes that are happening within the market. And so I'm swayed by Dr. O'Connor's comments, Commissioner O'Connor's comments, frankly, because if there are people on this group who will create that kind of reaction simply because of what they have said and done in the community, they can provide input, but you want to be protective about the work product, and some of it is directly affected by who is at the table.
Yeah, so also at the risk of exposing my bias as an employee of Shore Health and someone that lives and practices on the shore like Jerry here, is the purpose of the work group to turn out something specific to the hospital in Kent County, or is the purpose to define a series of challenges and potential solutions to the problems of rural health care in those 5 counties? Because I think that question is really the heart of what we're dealing with here. I agree. This, the list is not perfect. I agree with Jerry, actually, that I would love to see some more actual frontline healthcare providers on that list. But as it stands, each of these people bring some bias to it, but I think they're also given a perspective, as you would also point out, that can offer an answer to some of those problems. Each of them come from a business. They come from some area of the economic and other aspects of life on the shore. And so I don't object to the list in total, and I obviously know a lot of them, and I'm okay with the list as it stands, if in fact the goal is to describe those list of problems. Now, if the goal is in fact to do something different than that, which is talk specifically to the needs of the hospital in Kent County, then absolutely there's problems that could emerge from this particular list of people. But I think we need to be clear on that. So I'll stop for a second, let Erin answer.
So thank you, Commissioner Weinstein, and if the senator would like to jump in here at any time, just let me know. But the goals really are what you said second. It's to look at the region as a whole, describe the problems in the region as a whole, look at it in the context of this changing healthcare landscape, and come up with some solutions that will be good for the entire region.
I would just agree, and honestly, as the representative of that area, I would love to see something that would prohibit that hospital from closing, or limiting services. We're working on that with other things, but I think you hit the nail on the head. This is about the second part of that, to be able to look at this focused 5-county area, how interacts with Shore Regional Health, what that looks like when you have a type of a system there. But to answer questions, and again, going back to what we looked at in Western Maryland, to be able to utilize this result to look at healthcare amongst all rural areas.
Let me just make it clear for one second. Initially, I simply wanted to save our facility, our hospital in Chestertown, and that morphed into this work group, study work group coming out of it, which just elated me. I was excited about it, and I think I'm looking at the bigger picture, and I think it's more important than just Chestertown. But when I saw the members on here, I just, it deflated me like right away. So, the application process too was a little bit confusing. Dr. Hershey's office had asked us for nominations. We had a little meeting ourselves, submitted nominations. At the last minute, we were told no, it's an online application process. So people either got frustrated or, you know, didn't bother pursuing it. So I think a lot of good people weren't considered.
I think we got all those people.
Yep.
Did you get
All of the people, Erica, right?
Yep.
Yeah, everybody that came in through us through email,
Got it.
we still put them in through the online process
Yes,
to make sure.
Senator Hershey and his staff put in about 20?
23 names.
20?
23. So 23 came just from people that contacted my office.
Yeah, so first off, I want to thank Senator Hershey for his leadership on the original bill and for coming here today as well as Erica Howard, his staff person who's here as well. I mean, keep in mind that this is a 5-county area. One of the challenges is as we move to a healthcare system that's more integrated, the concept of what constitutes a regional system is being articulated. We felt that we needed a couple representatives from each county. That is the prime reason why it swelled to close to 30 people, because there isn't consensus among the counties currently. I think Senator Middleton, correctly said, let's keep this narrow to start with, but and focus on the challenges in the midshore, being at the same time mindful that perhaps these can be expanded to other rural areas of the state that have different challenges as well. So I sort of want to defend the fact that we think we are inclusive of all 5 jurisdictions. I think that it's appropriate to have the CEO of the regional health system included, because that regional health, I don't see any other health system waiting in the wings. Shore Health has to be part of the solution if we're to develop a health system that serves all of the jurisdictions and all of the residents of that county. And to shunt that person aside, I think would be a serious mistake in developing a solution. I'd note that that we have, I think, very balanced representation: behavioral health, long-term care, primary care, acute care. We are addressing the workforce issues by bringing in the head of the statewide Area Health Education Committee, Dr. Colgan, by some affiliation with University of Maryland. Poisons him, but I think unfairly, because the AHEC on the Eastern Shore and the Western Maryland as well have done a pretty good job. In Baltimore City, there are challenges. So I think I want to recognize the work that Aaron did on this, putting the group forward. Not perfect, larger than probably, I think Dr. O'Leary is correct, Dr. Stollenwerk correct too, but we did the best we could. There will be plenty of time for public comment, including the opportunities for both primary care providers and members of the public to comment. The first meeting is really going to focus on a summit, half-day meeting that will break into issue areas, and we would include others that did not get selected to participate in those, so that we have as broad a perspective as possible going forward. And we're certainly going to be keeping the commission informed as we work through all the challenges that we are going to face. I'm very impressed with the willingness of both our chairs. We did go through a couple people, several recognizing the challenges, said thank you, but no thank you. So it's not these are not well-paying jobs that people are taking on. And I think that sometimes by putting a person in a chair position, they shed some of their biases that they might normally hold in trying to build consensus. And if that's not the case, I'm sure that we will be talking with those issues.
Thank you, Ben. Just one clarification question, and then I'll go around for last questions and comments. Aaron, the feedback that were for a couple of people in the room that there were not sufficient, just call it frontline providers sort of on the group. Were there people who fit that description who applied and were not selected in the group, or there was just a dearth of frontline provider interest?
No, there were people who fit that description. Trying to keep the group size down.
Yeah.
The more providers we added, the fewer business people. You know, I mean, there were always trade-offs. So, you know, I apologize that we didn't get enough, you know, frontline providers, but we also needed to bring in other stakeholder groups and weighing that against keeping the group from getting more unwieldy than it's likely to already be. So, you know, we just made some judgment calls and some tough choices.
Yeah. Okay. Thank you for that clarification. Last question.
Just a follow-up question, and this is spurred by Ben's comments. Is there the option of, I mean, in my experience, chairs have a lot of influence on how a group goes. So rather than shedding bias, actually, the chair often, I mean, that can drive where the group goes. I'm wondering if there's, at least to be responsive with some of the feedback that you're hearing, whether there's a way to, even if it's just select somebody else to be a chair as who's already on the work group, just as an option.
Mr. Chairman.
Yep.
So I just want to weigh in, given the other comments that have been made. I've known Joe Ciatola professionally for over 20 years now. He can be very loud and express his opinions in the appropriate environments, but when asked to take a leadership role and look at things in an unbiased fashion, I think he will do a stellar job. I think he probably does have some biases. When there's no conflict of interest, there's no interest. When you have some knowledge of a situation and the overall challenges of rural healthcare delivery like Joe does, you're going to have some preconceived opinions that you bring to the table. I think all of us do in certain situations, and the ability to sit, listen in an unbiased fashion and adjust those opinions is what you're looking for, and I think Joe has that.
Can I respond to that?
Sure.
I appreciate your comments. Thank you. It's just he specifically seemed to partake in the dismantling of services at our facility during the time period where Mr. Kozel said, no, that there's nothing's going to change, nothing's going to change. And yet I saw behind the scenes, and obviously Dr. Ciafolo verbalized that we didn't deserve to have an ICU.
So
I've been working for 32 years, and I think I can make a better judgment about that than he could, who I'm not quite sure he ever walked the halls of the hospital. I never saw him in the hospital.
So can I just answer Diane's question? Mm-hmm. I think there was a question in there about picking, yeah. So it's not, when we chose these two chairs, like Ben said, we had lengthy conversations with multiple people on these lists, on this list. And part of what you're looking for, quite frankly, is someone who is interested in taking on this very, very, very difficult task. Both of these individuals, when we spoke to them at length, were interested in taking on this task, and we talked to both of them about their potential biases, being that, you know, one is a consumer in Kent County and from Kent County. You know, she may bring certain biases, as will Dr. Ciatola, and they both assured us that they are up to that challenge. So I think to just, I'm not saying we can't, if that's the will of the commission, start all over again, trying to pick somebody else. But we would have to then go through this list and try and find somebody else who can balance off the other co-chair nicely, maybe bring a different perspective. That is what we were looking for. We're looking for more than one perspective.
Yeah, and so just let me build on that, I think, on what the options are that we have in front of the commission right this second. So we, the action was to approve the chairs and the membership. Thank God for Robert's Rules of Orders, we didn't put the motion on the table before having the discussion. So you can actually put a motion and sort of out there. There's, there's 4 levels of feedback I heard. One was, sort of a set of advice around how to structure the work groups, going forward, that I think will be duly noted for future actions, but it's not really that actionable today. There's been some feedback about the chair, which I think would be very difficult to incorporate that action and besides up and down into a revision of the amendment. Some concerns about specific members that, again, I think it would sort of be, it's hard to kind of get into that level on a vote. It's sort of up or down or table. And then the one that might be actionable is, hey, if it's 30, could you go up to, I don't know, make a number, 32 or 33 and get some additional, of the other representative. And that's really kind of, I just wanted to get a feel for, a bit from this group. So before we put an amendment on the table, or Aaron, your perspective of what's actionable or not out of this feedback before we put a formal motion on the table.
Well,
because the commission can certainly say, hey, we have concerns, and then we say, defer or what have you, and then we go offline and figure.
Yeah, I mean, I think
vote it all in. Yeah. I
think that we could do that. We could defer to July. If you all are unhappy with this list, Ben's grabbing his microphone. I see it. I don't think that that's advisable.
And also, just as a point of procedure, the commission does not have to, by any means, vote on consensus. There's lots of times in which there's been, concerns from a minority, and we vote on it anyway. So I'm just trying to frame out the dialogue. That's all.
One other comment I'd like to make is if this study group truly is going to understand the problems in rural medicine, I think that the business people you have on here are great, but they don't understand difficulties, the type of patients, the demographics of the patients, the age, non-compliance, the transportation issues, the hearing in their office every day. My car broke down. I can't get there for 2 hours. These issues, I don't think, can be reflected by the members of this study group. And if you really want to address rural health care, I think you need people on there who understand these issues.
Any comments to that discussion?
I was going to make a motion that we move forward by voting on this list, if it's okay to do that at this point.
Okay. Before we get to a motion, let Ben say one more thing.
Right.
Then.
So, I think we have to follow the law. The law said business, labor, healthcare practitioners, members of elected officials. So, and I mean, one of the problems with healthcare today, I think, is if it's an inside game, the solutions that we're going to come up with, they're just not going to be as meaningful. So, maybe someone, quibbles with Bob Grace being on there. I was there when Senator Hershey convened his work group in just January, and frankly, Bob Grace had concerns about broader economic development terms in Kent County that are important, that may not be necessarily issues that physicians grasp every day. There are we have Kevin Beverly, a long-standing, grew up in Dorchester County, pulled himself up by his bootstraps, now funds a scholarship program in Dorchester County. And, to say business doesn't have a place at the table, I think we're missing the point here if we want to just focus this on an inside game where we're only focusing on practitioners. They are extremely important. I think that the expertise we're bringing in from outside that will conduct the study will inform the work group, even as the work group guides that study group. So I think we tried to balance it. I think that Dr. Ciotola, because he is an EMS provider, as well as a health officer, as well as formerly on the Chestertown board, and currently on the broader Shore Health Board, brings a couple different perspectives that are valuable moving forward. And I'm not sure by delaying we're going to do any better. We're going to offer the entire communities in the 5 areas opportunities to participate in the summit, and I think that's going to be very important in guiding the work group as well as the study team moving forward.
Okay, thanks.
I've long shared the concern that the ground floor healthcare providers, the people who actually take care of patients on a day-to-day basis, like me, be involved in the discussion because it brings relevance to it. It's important. But having the broader group involved is critically important for all the reasons that Ben pointed out as well. I think that I just want to make one more plug for Joe, having known him for a long time and having known the opinions he can express and his ability to step back from that in leadership roles and listen to all sides of an issue. He's been a ground level provider. He's been a ground level orthopedic surgeon, and he's been somebody who appreciates the need to listen to that group. I think he'll do a great job in this role, and I share Adam's concern and Ben's concern that we should move forward and approve this today.
Okay.
Yeah, I wasn't knocking the business people. In fact, Bob Grace was on my campaign, so I love the fact that he's on it. All I was making was observations. There were no trench people in it. That's all.
Okay. Adam, did you have a motion?
I move that we vote on the list as is and move forward.
Okay. So there's a motion to approve the shares and membership. There's been a second. Any additional discussion or comments?
I don't know, Dr. Ciotola. I'm just concerned about the concerns raised, just because I want the outcome of this work group to be trusted. So I just want to reiterate my concern about having somebody who is even volatile as far as mix of opinion as the chair creates. I mean, you create a disadvantage for the work group from the get-go when there are people in the region who have such strongly held opinions on different but strongly held opinions about someone. So again, I don't know the person. I just hear the concern, which raises concerns for me.
This is not just my opinion about Dr. Ciotola. If you want to poll any healthcare provider at Chester River, I think they give the same assessment, that they'd be very disappointed. And I agree with Diane that it would be a real letdown and lose any confidence in a study that's chaired by someone like Dr. Ciotola. Can I make a motion to accept, with the exception of putting Dr. Ciotola?
There's
already a motion on the floor?
Yeah, there's a motion on the floor at this point. So, so what's that? Oh, you could certainly propose an amendment if you want to, and the chair would entertain the amendment if you want to do that. But I think there's a motion on the floor.
Can I make an amendment now, or after the motion?
What's your specific?
The amendment is to accept the list as stated, except move Dr. Ciotola down to membership instead of chairman, and replace him with Rich Colgan.
Okay. So you're proposing an amendment in which you're changing the chair from
Dr. Ciotola to Rich Colgan, and put Dr. Ciotola as a member. Is that okay with you, Diane?
So can I? Oh, I know it's the commission discussion, but can I just jump in here for a second? Well, we haven't spoken to Dr. Colgan about whether he'd even be willing to do this. When we were choosing chairs, we thought long and hard about whether the chairs should be from the area or not from the area. And the decision was made that they should be from the area, but there should be there should be representation from Kent County, and there should be representation from maybe people who have a different perspective than Kent County, which is why, you know, after speaking to a number of people on this work group list, we settled on these two individuals. You know,
just in terms of being practical, I mean, if we want to sort of unbundle this, and again, in the spirit of being fair, I do want to unbundle certain things. The chair here would suggest if you're going to make an amendment that the decision of the chair is deferred and come back to as a you know, additional action, because I do think that in judgment, sort of making a very quick decision on a second chair is just not a good action to do.
Lawyers are frowning at you.
What? Lawyers do it all the time, did you say?
Our lawyer is frowning at us.
Yeah. So right now, there's not a second on this amendment. There's not a second on this amendment. So therefore, we don't have to act on it. You can withdraw your amendment if you want, and if you want to make an amendment. And what does our lawyer say? Yeah, is there a second? Okay, so there's no, that amendment was not on the table. If there's another amendment?
Yes, I have a suggested amendment.
Okay.
So to approve the slate of individuals and then come back to us in July with suggested chairs and look at who, I mean, and provide to us a bit more information about who was considered, to try to get to the very things that Aaron's talking about in terms of representation from the local area, different perspectives, but again, being sensitive to the trying to, frankly, avoid volatile reaction from the community about who the chairs are. So my amendment would be approach this as a slate of individuals and then come back with a suggestion for who the chairs would be, which gives a little more time.
So your amendment is to approve the membership and to have a separate decision to approve the chairs. Yeah, that's what I'm.
I guess what I'm suggesting is that the chairs would be part of the membership. So of this slate of individuals, including the chairs, then identify who the chairs would be from these individuals.
To approve the entire membership, and then the chairs would be second. Before we take any seconds, I just want to understand from.
I want to clarify.
Is that even practical?
Yeah. So this month you would approve the membership, and then we would come back and approve the chairs at a later date, potentially next month. Is that what you're saying?
No, they would be considered in the membership. Those two chairs would be considered in membership right now. Approve them, and co-chairs to be decided later.
And of the so thinking of this rather than chairs and members, it's a list of all of the individuals who would be on the work group. That would be what is approved, and or for a vote. And then of those individuals, come back with the revised recommendation for who the chairs would be.
So we would have to do some work then. We would have to go back and you know, work through who could be the chairs. In the law, the commission it has to approve the chairs as one part and then membership as a second part of the law. That would delay some of our work, since we want to get working with our chairs as soon as possible, whoever they may be. And I just think that, you know, we would be delaying the beginning of this process for at least a month.
What about just having one chair and put Dr. Ciatola in the membership?
So from a practical standpoint, in having a work group, you know, again, we want two perspectives. We don't just want the chair as a Kent County perspective. And also, practically, when you have two chairs, if one chair can't come to a meeting, you know, you have the other chair. With all the work that needs to be done with this work group, we believe that we really need to have co-chairs, because it is going to be a lot of work, and it's probably too much for one person to take on. Not saying anything about these individuals, that these individuals are not be able to take it on, but I don't think anybody could take it on all in and of themselves.
So, okay. Senator,
No, I'm not going to comment on this.
All right, fine. Okay. So
Realistically, what are our options then? We either reject this or we accept it. Is that really what it comes down to?
well, I think there's been a concern expressed about, delays, and so I think we're making that as an educated, decision. So I do think the commission has the authority to, defer the decision for a month if it feels like it, or to do any of these other options. So I don't think, we could have that amendment. We don't have a second on that amendment yet. I'll ask for the second in a second. But is there a second on that amendment?
Can you
A
restate
second. What's that?
Can you restate it to make sure I got what the amendment was?
So the chair interprets Diane's amendment as saying she would like to have us approve the membership list as is, including the two people who are chairs. They would be members. And then for Aaron to come back within the month to come with suggestions around the chairs. And so that's the amendment.
And if we don't vote for that amendment, we go back to the original motion, which was approve the list and chairs as, and then we would vote on that. I'm just trying to make sure I understand.
Yeah.
So can I just, looking over at council right now, we would have to have the chairs approved in another public meeting, which our next one is in July. Correct?
Unless there was a special.
Unless we hold,
There's a
okay.
call. Yeah. So is there a second on that amendment?
I already seconded.
There's a second on Diane's. So let's have a discussion of that amendment then, to unbundle this decision. And so just to be clear with council, when we're voting on or discussing the amendment, it's whether we should split this too, or we're actually voting on that. We're voting on the membership only option at this point.
That's Diane's amendment, and so that's the motion. And if the amendment carries, then you won't go back to the original motion. If the amendment fails, then you go back to the original motion.
And if the amendment carries, we're done with the decision. Yeah, that's okay. Fine. Let's have discussion.
So I'm going to speak against the amendment. I also know Dr. Ciatola very well, since he seems to be the point of objection. He is the EMS director for the county I live in. I work with him on some telehealth grants. I have a lot of connections. He is, I think, an excellently well-positioned person to take this, and I think unbundling this particular group of chairs from the rest of the committee would probably hinder the progress that we need to make on this topic. So, thank you, as I throw him in.
Okay. Yeah, I got you. That's what I thought. Thank you for that clarification. Just council informed me that the actual vote is on, do we vote to amend the initial motion? So it's just, do we think the amendment is a good idea or not? And then we would vote on the amended motion. So, any other comments about the amendment?
I was just, I didn't get everything you said because I was involved in that discussion in the back, but just to make sure that it was stated, I think that the work of the group needs to go forward. The staff has done an awful lot of work putting this together, and there are always going to be people who are opinionated, and I do believe that by being opinionated, you could sort of declare that you have an interest in the topic, and you bring something to the table that's very valuable, and I would just encourage us to move forward in this situation.
I've hesitated to do this, but it's, I think at this juncture it's important that I also share my past professional work with Dr. Ciatola as a fellow health officer, and then when I was at the state, I guess technically responsible for the cadre of health officers around the state. Joe can be certainly a spark, but he's also demonstrated, in my opinion, a spark of innovation, particularly around workforce and around blending paramedics with community health workers and doing some very innovative things in using a workforce that's available in a rural community and pivoting through training that workforce to do chronic disease management. And so there's a project that he's been funded now by the state for a couple of years that's shown some real success. So I want to speak on that because I think that it's important not only to recognize the work that the staff has done in trying to get the right people and the right perspectives and geography and all that straight, and I'm not sure even there's in this cadre of 28 people there's someone else willing to do that, but in my experience, Joe Ciatola has been really an admirable pace setter. So I wanted to share that.
I want to make a comment. I don't actually have a perspective on the proposed chair, but I do have a perspective around staff, which is I think that staff has actually shown a lot of good judgment about how to actually assemble the teams to make the right adjustment, and then sometimes sort of changing the ingredients at the last minute can be really fraught with consequences. So I would be concerned about unbundling the decision. So, other thoughts? If not, let's vote.
Well, just one more comment about Dr. Ciatola and EMS. He's involved in EMS in Queen Anne County. That's not quite the same as Kent County. The implications to our EMS in Kent County would be disastrous should we close inpatient care here. The transportation issue, the monetary implication of addressed to the state to fund transportation of patients to a regional facility was astounding. Queen Anne County doesn't have that same problem. So it's a different animal. EMS, Kent County, EMS, Queen Anne, totally different. So the system works much easier in Centerville.
Okay. So let's vote. Again, we're voting on the amendment about whether we should, splitting this membership and chairs should be voted on. So all in favor of the amendment, raise your hand. All opposed? The amendment does not carry. So now let's go back to the original motion on the table, which is to approve the chairs and the membership as outlined by Aaron. Any further discussion on this? If not, let's move to, sure.
One final comment, and I understand, and it is hard to do this. I do understand how hard it is. I would appreciate that it is communicated in some way, and certainly staff understands this, the concern about a productive work group. So that's all. Just in terms of the volatility, and just be attentive to that. I guess that's the only thing I wanted to say.
Yeah, and I think in the past, I mean, I'll just take that as put on the record that the chair asked staff to kind of take the spirit of this conversation, and as they're putting together the work group, and I think staff has shown lots of good judgment in that.
Commissioner Metz is on the phone.
Commissioner Metz, okay. All right, thank you. So, Commissioner York?
Just sent an email saying he's trying to express
Okay.
point of view on this
Okay.
issue, and he's having trouble. He's muted somehow.
Okay. Can we fix that technically? Commissioner Metz, can you say something? Can we hear you?
Yeah,
we
can you hear me now?
Yes, we can. Please.
It's been a little bit of an adventure. The one thing I would weigh in on this, and I certainly am very objective in this process because I know none of the folks involved, but there seems to be quite a bit of, for lack of a better term, politics here, and obviously this is leading down the road of concern about whether or not a hospital continues to exist or some form of healthcare entity. I would just caution that the process we went through in Western Maryland through the consolidation of both Sacred Heart and Memorial Hospital can be quite contentious, so we make sure that we have all the right players on board in a process that will go forward as smoothly as possible, because it's obviously going to be, just from this meeting today, very contentious. Thank you.
Thank you. Let's move to a vote. All in favor of the motion from Commissioner Weinstein? Aye. Any opposed? 2. All right. Motion carries. Thank you very much.
Thank you.
Appreciate the candor and the discussion.
I think that if commissioners have some reservations, I would note that Senator Hershey, Senator Middleton, Senator Mathias, Delegate Hammond, Delegate Sample Hughes, and Delegate Jacobs are also on the committee. I think they're all going to be, we will convey that, as will, I'm sure, Senator Hershey, on the nature of the concerns here. And we'll all be mindful of ensuring that the chairs are fair and balanced on this issue. It's really tough. I think what we see here is a microcosm of the challenges the 5-county area faces.
Thank you for your time. Let's move to agenda item number 5, which is around electronic health record incentives. Private health insurance carriers have awarded over $9 million in incentive payments to primary care practices in Maryland since 2011. These payments complement payments made by the federal government under the Meaningful Use Program, and Angela Evat will present proposed changes to the EHR incentive regulations that will extend the program through 2018.
Thank you. Good afternoon, Commissioner. I've spoken with you a few times about our EHR incentive program, and I just wanted to quickly overview a bit of the background. In 2009, a law was passed to require the MHCC to establish electronic health record, or EHR, adoption incentives from certain state-regulated payers. We worked with a work group to develop the recommendations that ultimately framed that program. At the time, the EHR adoption rate was fairly low at 19% at the state level and 22% nationally. And that law aimed to increase the adoption of electronic health records as well as its meaningful use. The regulations went into effect in April 2011, were amended slightly in October of 11, and again in June of 2014 to align with the federal incentive program. Just a reminder of some of the key program elements. In terms of eligibility, primary care practices are eligible, and that includes nurse practitioner-led practices. In order to qualify, a practice must adopt a certified EHR as well as attest to meaningful use at the federal level. We understand that some practices would not qualify for meaningful use, and we added an additional provision in which a practice can meet NCQA PCMH, primary care home level 2 certification to also qualify for this incentive. The 6 largest carriers that participate, and that includes Aetna, CareFirst, Cigna, Coventry, and Kaiser, and United. It's a one-time incentive payment per payer per practice, and then it's an incentive of up to $15,000 based off of their practice panel membership at $25 per member. In current regulation, the program sunsets at the end of 2016. Staff assesses the program through payer reports of payments made. And what we've noticed since October 2011 is that the impact on advancing EHR adoption meaningful use has been moderate. In total, incentive payments have exceeded over $9 million, as the chair had mentioned, and payers have paid out over 1,600 payments to those primary care practices in the state. What we've noticed is that there's an average annual growth in program participation at about 29%. And staff frequently communicates with primary care practices to understand some of the challenges of participation in the program. What we found is that obviously there's a lot of competing priorities with practices in terms of the new programs they have to implement, and EHRs are on top of that, as well as meaningful use. A lot of practices have chosen to defer meaningful use participation until the final deadline of March 2017, as well as some of the awareness about the program is somewhat challenging. First, you have to know about the program in order to participate. And additionally, some practices just don't think that the incentives are enough or sufficient to go through the meaningful use requirements. In April, we reconvened our work group to discuss the impact of the incentives on advancing meaningful use of adoption. There are opportunities to increase meaningful users by extending the sunset date, and we also want to strategize around increasing program participation through awareness. The work group recommended that there would be a one-time extension date of the sunset by 2 years, so this will be through December 2018, and also work with our stakeholders to expand that awareness of the program. In terms of outreach activities, we plan on focusing on practices that have not adopted HR, but also practices that have adopted a certified EHR but have not gotten to meaningful use. And then finally, the third set would be those who reach meaningful use but they haven't taken advantage of the payer incentives. In terms of outreach, we've found that fax blasts, emails, newsletters, and website posts have been helpful, and we plan to continue to work with our partners at MedChi, the Maryland Nurses Association, as well as DHMH and CRISP to increase those outreach activities and build awareness. So finally, staff recommends that the Commission adopt the recommended amendments as proposed permanent regulations to extend the sunset by 2 years.
Before we take a motion, can we just have some questions? And maybe let me tee it up. You know, I think there's been a fair amount of activity in this space that I would characterize as saying that I think people have realized in sort of looking back that some of the assumptions around what was meaningful use and how it would actually contribute to quality and output may have been mistaken. And lots of people agree that may have different views about how mistaken it has been. And so I just, now that we have sort of this new perspective and new, you know, views, has that been taken into account? And I'd just be curious what happened in the participant work groups about, you know, how valuable the current construct of meaningful use is.
So there was discussions in the work group around the value of the payer incentive program as well as the value of meaningful use. What we sort of explored was the opportunity to add different requirements around this incentive program to align with some of the movement happening at the federal level in terms of value-based care delivery models, as well as participation with PCMH programs and the like. What we found was that there wasn't much of a temperature for that, but the carriers were willing to at least extend this program for 2 more years, knowing that some practices are still, you know, working to finalize their adoption of EHRs and attest to meaningful use to then take advantage of this program.
Are there questions?
Yeah. The beginning of your presentation said that Maryland was at 19% compared to 22%?
In 2009, I believe.
What is it today?
So today, office-based physicians are at 66%.
What is the national?
At the national level, the CDC usually releases data. They're a bit behind on the 2015 data, but in terms of 2014, I believe the was 54%. Let me go to my record.
Okay, so we're extending the program even though now we're well ahead of the national average.
So, Commissioner, since the program went into effect in about 2009, we spiked up about trailing the national average nearly 10 percentage points each year. The extension of the program, if you look at it from the perspective of what the chairman said about, are these incentives more about checking the boxes and essentially rebates? And we thought long and hard about that when we worked with the work group about extending it. And part of the considerations for the recommendation was that if we're thinking ahead to MACRA, and we're thinking ahead to the NIPS program, we're thinking ahead to the advanced payment models, if you will, the alternative payment models, health IT has to be an integral part of that infrastructure. And we're worried that 33% of primary care practices, and this is what this incentive goes towards, will be left behind and trailing into the MACRA timeframe. So we're the consensus was, well, let's see if we can get the hard to get, because that 33% are really the hardest, that's the last mile, but the longest mile, if you will. So we're not expecting huge results, but if we can help drive it further, then there'll be less confusion around practice transformation, because practices will have the infrastructure to support what's inevitably coming down the pike.
So, and that leads to my next question, which was going to be, how much do you expect this will, the total incentive over the 2-year extension will be?
So it would be a best guess at that, and I believe we probably will see not more than a couple hundred practices. The panel sizes drive the actual payout. We have a finger to the wind of 300, 400 practices that we might be able to get. If we'll probably tip the scale to about 100, we're thinking, because there'll just be some that never will go forward, because the back of the envelope math will say it's just not worth it.
And then 100 practices, what would the dollar amount be?
You have to do an average panel size, and we could work that up if that would be helpful. But if you do the math of what 2,000,
I'd like to know. You may see this going over time. It's always easy to tack something on to what the insurance rate payers pay for, but it's important to realize that money is not coming from a payer like Care First. It's coming from the insurance payers in the state, and we simultaneously bemoan high insurance rates and treat it as a piggy bank. So I'm not saying this is treating it as a piggy bank, but expressing that concern, I would like to know how much that's projected to be.
we can find that out for you.
Yeah, I had the exact same two questions in terms of what do we think this bottom line is going to cost, and it does. It's back on the the premium payers. It goes in, it's going to put upward pressure on premiums. The other thing I'd like to ask a little bit about is your interpretation of MACRA. So, coincidentally, yesterday I was at another commission that was being briefed by CMS on what they want to do with the MACRA changes and the way they want to fold kind of what we currently call meaningful use. They're going to change the name because that's what CMS does. And they're going to roll it into both quality and cost, as well as, I forget, you would assume access, but I don't think it was. It was more like proper resource allocation or whatever. That's built into MACRA, and we'll do this. So this 34% or so who are holdouts at this point, who haven't responded to a positive financial incentive, which is absolutely their right to do. But I guess there's another way of looking at what the feds are doing, is that if all of a sudden this now becomes part of your bonus payments having to do with both cost and quality and your other payments, are making, whatever, 1,200, a couple hundred, how many, each practice is getting, what, $15,000 or so?
That's the maximum they could get, and it's based on $25 per member per.
I guess what I'm thinking is, given what the feds have put in order, they're suddenly going to be, you're being very nice about this. Let's help them get ready for this thing that's coming. The other, the incentive, the motivation to move and finalize this, the feds are going to kind of do it for us anyway. I think that was my interpretation. The MACRA had much stronger kind of motivation to do this, and you have it as a practice. You have a choice of kind of how you can meet certain, get your points under MACRA bonus programs. You can do it through more cost. You can emphasize more different things. So I guess that idea of if these practices really don't want to do it under the current incentive system, and there's another larger incentive system, both positive and negative, it's like a plus 4% bonus payment and a minus 4% bonus payment if you don't meet not only the meaningful use but the other kind of concerns. Is this time for us to step aside and not put the upward pressure on the premiums of the citizens of the state and let the chips fall where they may for the feds? Because you certainly have now done this for how many years?
Since like 2009.
Yeah.
Well, actually, 2011.
2011. So about 5 years, and you're asking for, you think it's a good idea to go 2 more. I guess I'm just thinking, well, certainly I would like to know how much more it would cost and what pressure it would put on premiums. But then also the idea, if there is this other change coming that is in some sense a bigger game, and is it time for us to step aside and let the feds do what the feds do?
So if I may respond, there's the meaningful use component that's out there that's part of this, where if you don't meet meaningful use, you don't get an incentive. So it is tied. It isn't. We took away the notion of it being a rebate and applied it to something, even though meaningful use in reflection isn't necessarily the best thing. I think everyone would say that about the meaningful use program. What led us to reconvene the work group and have these conversations is that the physician community has felt like, at least anecdotally what we're hearing, is that there's been a lot of pressure to do a lot of things. Just the ICD-10 conversion and preparation had slowed down a lot of practices on the meaningful use and slowed a lot of practices down around implementing technology. So their concern is there just hasn't been enough time to let them catch up. And this isn't going to be a lot of practices, but there's been that general sense that they just need more time. So that's what led us to convene the work group and raise the question. We did not get any concerns from the carriers, at least in the work group, that there was a problem with extending it. So we did ultimately support those recommendations and thus bringing it to you today.
Can I ask one more? So if you're estimating 100 panels, I had forgotten about the $15,000 maximum. So will you be talking at 100 panels, $1.5 million or less for the whole 2 years?
That would be correct if you use that assumption.
So it's if you're by the 100.
And at the high end.
That's the high.
Yeah.
Yeah, that's the high
It'd
end.
be $1.5 million if all 100 panels got the maximum.
Which is the high end.
Okay. And spread across the industry. Which somewhat alleviates my concern that this isn't a big dollar amount.
So your ad hoc actuarial analysis would be that the upward pressure on premiums would be de minimis?
If you want to take actuarial analyses from a lawyer, you can.
Are there comments? Yes.
Just one thing to clarify the record. I'm not going to argue with you, David. Don't worry. All carriers did not participate and agree, just to clarify the record.
So
On the work group.
as I would say, we had representation that presented themselves to be representing the carriers. So if that's not the case, then we were misinformed. So my apology.
Other comments? Not, let's, can I get a motion to approve the proposed changes to the electronic health record incentive regulations that would extend the sunset from 2016 to 2018? Is there a second? Any further discussion? All in favor? Any opposed?
Abstain.
One abstention noted.
Thank you, Mr. Chairman, Commissioners.
Okay. All right. Agenda item number 6 is telehealth grants, the round 4 awards. Okay. Earlier this spring, the Commission released a telehealth technology pilot, round 4 solicitation, seeking applicants who could demonstrate effectiveness using telehealth to provide remote access to primary care providers and using in-home telehealth monitoring devices to support case management for chronically ill patients. Staff received 6 applications, and Angela will announce the awardees.
Thank you. Again, a 2014 law allows MHCC to directly award grants to nonprofit organizations and qualified businesses. Since October 2014, we have awarded 3 rounds of telehealth grants to a total of about 8 organizations, in the total amount of over $115,000, I believe. These telehealth use cases provide us the opportunity to test the effectiveness of certain technologies in various settings with different patients, different areas, different protocols. And what we hope to do is take the challenges and the lessons learned from those telehealth projects and build on the successes of the next, as well as provide information to the healthcare community about some of the best practices of the telehealth projects. We also hope that these projects will help to inform potential policies to support the advancement of telehealth, as well as the design of larger telehealth programs. Just a quick overview of our previous telehealth grants. Under round one, which was recently completed in October, and we presented to you a report on those projects. These were awarded to Atlantic General Hospital, Dimensions Healthcare Systems, and the University of Maryland Upper Chesapeake Health. They worked to demonstrate the use of telehealth in coordinating care delivery between a comprehensive care facility and acute care hospital, where the patient was monitored at this facility and was provided telehealth video consult with a hospital provider if there was a change of condition. This helped to reduce the transfer of patients to the hospital when it wasn't necessary. Round two grants began in June of 2015. They'll conclude at the end of this year. Those were Chrisfield Clinic, Lorien Health Systems, and Union Hospital of Cecil County. These projects are to demonstrate the impact of remote patient monitoring on hospital readmissions in various settings. Crestfield Clinic being one of our rural nurse practitioner-led practices that's working with students in that county. Lorien Health Systems works with those patients discharged from the nursing home to monitor them at home with a case manager. And then Union Hospital does something similarly, but for patients that are discharged from the hospital with chronic conditions to avoid readmissions. And then finally, our round three folks began in December and are just kicking off their technology implementation, are Associated Black Charities, Gerald Family Care, and Union Hospital of Cecil County. They are demonstrating the impact of using telehealth to improve the overall health of the population being served, particularly Associated Black Charities working with community health workers out in Dorchester and Caroline County to provide video consults with the Choptank community health nurses when needed within the home of their patients. Gerald Family Care is working to increase access to specialty care through video telehealth consultations. And then Union Hospital is also expanding on round two to continue remote patient monitoring their patients in addition to interfacing that technology with their hospital system. So under telehealth round four grants, the aim is to demonstrate the use of technology to support value-based care delivery in primary care and to expand patient access tailored to meet the needs of those communities. And under round four, they'll be using technology in conjunction with care coordination to improve population health, and they'll also be working with utilizing the services of our state-designated HIE. We also are requiring a 2-to-1 funding match for these grants, and again, we'll have an 18-month project. Our first applicant is Gilchrist Greater Living Practice. This is a comprehensive geriatric primary care practice that is providing patients who are homebound with services either at the nursing home, within their office, within their home, or at the assisted living facility or hospital. The project will utilize remote patient monitoring for these patients for 24/7 coverage. They'll be matched with a care manager that will be able to monitor that patient remotely and triage the need to either visit that patient or have that patient come in if needed. What they hope to do is access for their geriatric patients by providing these remote services, and they've requested $56,000 and plan to match at $120,000. Our second is MedPeds. This is a primary care practice with about 8 providers, and they are a PCMH practice that's planning on demonstrating the impact of on care delivery using mobile devices to provide 24/7 telehealth services to their patients through a mobile app provided by their EHR system, ECW. This will allow their users to have access to their electronic health record, as well as to schedule office visits, including an e-visit with their provider. The goal is to increase access to their primary care provider and support patient engagement. And they're requesting a total of $61,154 and plan on matching it at $122,000. In terms of next steps. We hope to launch the projects this month and go live fairly quickly with their technology by September. We hope to be back here to report on their progress in April. And finally, they would submit their final reports in December 2017, and we release that to the public in March. That concludes my presentation. I'd like to take any questions.
Any questions? Adam?
I just want to make the comment that you guys I really appreciate the work you're putting into this. There's a lot of stuff going on in this space that I'm dealing with in chronic disease management, and lots of small projects at this point is probably the right way to go about it. I once again encourage you to publicly publish the consolidated knowledge about how to implement these things, because there's still a lot of confusion, and until the payment methodology catches up, no one's going to be doing it, but you're probably learning a fair amount of wisdom from the problems these people are experiencing along the way. So, thank you.
I should probably know this. Where's the funding for the grants coming from? Is that just the state budget?
Our own budget.
And then a second question, if I recall, we saw the round one presentation a month ago, and it's great work. Is there any way for us to look back, say when we're reporting on round 2 or 3, and just know, are they still using it? It seems to me every one of the 3 folks with the grant came and sat down and said, this is paying for itself. It would be nice to know if a year out or 2 years after the grant, are they still using that? Have they made real changes in what they're doing, even when there's no grant to support it?
So the PCORI grant application was an outgrowth of what Lorien learned in Harford County, and so it was a multiplier. I think we wouldn't, had we not awarded Lorien and Upper Chesapeake those funds to test use of telemedicine for patients in skilled nursing facilities, we wouldn't have been able to submit the PCORI grant. But, of course, they're still using it as we're going forward. So the answer is on some of the grants that have completed now, we think the providers are continuing to do that. David can probably comment on Prince George's.
Yeah, that's a great question. Thank you to our Executive Director for really guiding us through this work effort. It's been enormously helpful for us. The point about sustainability and do these projects perpetuate, they do. One of the requirements of the application is that they outline sustainability. We've been back to see a couple of the round 1 grantees already, and they're expanding their models. So it gives us a great deal of confidence. And as we work with the round 2 and round 3, we're trying to scope these use cases in such a way that you learn from them, as Commissioner Weinstein noted, and we can disseminate that information. But by and large, that it's you plant one seed and watch it grow, and it's sort of like the weeds in the garden. They just start popping up elsewhere with these infrastructure models, and we're very excited to see how this is working out.
Okay. Terrific. Thank you very much.
Thank you.
All right. Let's move on to the next agenda item. Just to set some historical context here, I think over the last couple of years, the Commission has been asking itself, how can we streamline certificate of need? And I think there's been a lot of perspectives on, how far, how quickly, what can we do, within the procedural rules, what would need legislative action. And so, Paul's here today to present staff's assessment of possible changes to these procedural regulations that govern CRN and other healthcare facility review processes. No action today. It's really to educate and inform and continue the dialogue. Paul?
Thank you, Chairman Tanio, members of the Commission. So we have spent some time in recent weeks going through our procedural regulations. These are COMAR 1024-01. I don't have a PowerPoint slide presentation. It's kind of hard to make exciting slides about amending procedural regulations, but you should have in front of you a document called Presentation Summary, MHCC Procedural Regulations, that kind of provide you a summary of the 4 issue areas that I'm going to concentrate on. And then you have a longer memorandum that actually gives you more detail on these areas and actually some other areas that I'll touch on at the end of the presentation. Want to first acknowledge the work of Sue Ellen Weidman, our Assistant Attorney General, and also the input we've gotten from Ben in this work. They've really done a lot of the work here, and we've tried to get the eyes of other staff as well on some of these issues. And with respect to streamlining, as Chairman Tanio noted, it's kind of a humbling experience because it's really difficult to find as many areas as we would like in these procedural regulations that really, I think, substantively streamline the certificate of need process. But it does help to clarify our thinking on, possible statutory changes that we might want to look at down the road that would provide more ability to kind of streamline this often cumbersome regulatory process. One other thing before I launch into the overview here, these regulations have not been amended for a few years. And we did have a few rounds of amendment prior to that time, kind of in the 5 to 10 year ago period, which were typically very focused on dealing with specific problems. They weren't comprehensive in nature. So what we're planning to bring to you later this year is a fairly comprehensive reconsideration of these regulations. There's a few things that aren't in the summary here, and I'm not going to really touch on them, but there are 3 areas that I just want to mention that have to do with recent statutory changes. So these will be additions. These will be addressing new issues in these procedural regulations. 2 of them are in the area of cardiac surgery and PCI. Now we have 2 regulatory processes that are different from certificate of need: certificate of conformance reviews in the area of PCI and certificate of ongoing performance in both cardiac surgery and PCI. And we've actually already done 2 rounds of certificate of conformance reviews, looking at establishing new primary PCI programs or moving primary PCI programs into elective PCI. The statutes, the statutory amendments in this area provided, enough guidance that we didn't have problems doing that, and I don't think we encountered significant problems in doing those reviews without actual implementing regulations. But those are areas that we will add procedural regulations on. And then the 3rd area relates to something that you've also talked about at this meeting, Senate Bill 707, giving hospitals the ability to convert or transition to freestanding medical facilities. That's an exemption review process, and that's Section 4 of these regulations. So we'll be expanding that to create procedural regulations for that particular type of exemption review. And again, it's a fairly detailed statute, so there's a lot of our work has already been done for us by the legislature. So issue area 1, qualifying as an interested party. Interested parties, as I'm sure most of you realize, are persons who typically are opposed to a project under review. If they qualify, they get to formally participate in the review, and they have automatic standing to appeal commission decisions on the projects. A major way that you qualify is by demonstrating that you're adversely affected by a project under review. And one of the first area that I'd like to talk about here is the definition of what adversely affected means. And what we are proposing to do is to maintain intact the part of the definition that would address someone who can demonstrate being materially affected in terms of quality of care at a healthcare facility that they own or operate. And the examples given in the regulation there are causing a reduction in the volume of services when volume is linked to maintaining quality of care, And another part of that definition is an interested party can demonstrate to the reviewer that the person could suffer a potentially detrimental impact from the approval of a project in an issue area. What we're proposing as a change here is to remove what is in the definition of adversely affected now. Anyone who's authorized to provide the same service as the applicant in the same planning region is automatically accepted as an interested party or qualifies under that provision. We're proposing to eliminate that, but then to maintain and modify another part of the definition. So an interested party can demonstrate that a healthcare facility that the person owns or operates would suffer a potential, or could suffer rather, a substantial depletion of essential personnel or other resources by approval of the application. So we're hoping, I think obviously, to tighten up the qualification criteria for an interested party through that change. Issue area number 2, acquisitions of healthcare facilities. Acquisitions of healthcare facilities are not regulated under CON. Only notification requirements are required, and they're fairly minimal. We are proposing to amend those notification requirements. We're proposing to eliminate some of the information that's required because we don't think it's necessary, and it's typically information that we actually would have in our databases already. But we want to get more information on the background of the purchasers of healthcare facilities. So we want to add to the notification requirements that you've got to tell us about the history of people who are involved in the entity that's purchasing the organization, whether or not they've had convictions, pleaded guilty or no contest, entered best interest pleas of guilty. As you can see, this is where our Assistant Attorney General got involved in writing the amendment. So it's a list of problem areas that one might have in their past. And what we're proposing here is that if those are identified for people proposing to acquire healthcare facilities, we would not prevent, we wouldn't have the authority to say you can't acquire a facility, but what we're proposing is that in those cases, when those kind of track record problems are identified, that we would bring that to the Commission in the form of a CON review. So we'll see how that goes. Issue area 3, the criteria for review of an application. There are 6 criteria established in the procedural regulations now that we look at in every CON review. Compliance with the state health plan standards, the need for the project, the availability of cost-effective or more cost-effective alternatives, viability of the proposal, the impact of the project, and the track record of the applicant in terms of previous CONs that have been awarded and their compliance with the terms and conditions of those CONs. We, from our experience in recent years in reviewing applications, there's 3 of these criteria that we are proposing to amend, and these amendments are really based on that experience, and they're intended to provide more precise guidance in terms of what we're looking for and how we think these criteria should be addressed in the context of a certificate of need review. So in this part of the summary, I've actually given you the current criteria and how it's worded. The first one being at the bottom of page 2, availability of more cost-effective alternatives. And here what we're doing is we're proposing expanding that so that we kind of make that into a more classic or traditional cost-effectiveness analysis type of context. So instead of just focusing on alternative existing facilities or actual formally competing applications in a comparative review, what we would be expecting an applicant to do in this case is really compare the cost and effectiveness of the proposed project with the cost and effectiveness of providing the service through alternative project plans that were considered or should have been considered informally. That's certainly something that we now encourage informally in applications, but also formally in some of the state health plan standards that we've developed in more recent updates of the state health plan. On the viability of the proposal, that criteria as currently written focuses on the availability of resources to implement the project, including community support, and the availability of resources necessary to sustain the project, which we think is a somewhat vague kind of statement, but we think it touches on the issue of financial feasibility over the long term. What we want to do is just have a more specific viability criterion that does note the need for demonstrating community support, but also focuses on the quality and the validity of the assumptions that are being made, the underlying assumptions that are used in development of the utilization and financial projections for the project, and also the impact of the project on the long-term sustainability and viability of the healthcare facility or service. A little more specific approach to the way that the current criteria is stated. And then finally, the impacts criteria. This is impact on existing providers in the healthcare delivery system. The current criterion focuses on impact on existing healthcare providers, impact on geographic and demographic access to services, on occupancy, on cost and charges of other providers, and on cost of the healthcare delivery system. So it touches the bases. What we're proposing is to reword that standard so that we have a little more specificity and precision on what we want to look at in this area of impact. So our list there is utilization and revenue of existing healthcare providers in the health planning region, physical and financial access of the service area population to applicable services, the level of use of existing service capacity, and that replaces occupancy, since obviously occupancy would only really touch on use of bed capacity, and we regulate facilities that don't have beds. So the cost and charges of other providers and the overall cost of delivering the services included in the project, which we think is a more precise way of stating cost to the healthcare delivery system. And then issue area 4 actually has to do with what happens after one gets a certificate of need. So this area is the effective duration of certificates of need and applicant responsibilities. Right now we have a set of performance requirements that I think we started out historically in this direction, and we've kind of continued in this direction, and it's now become, pretty dysfunctional. But right now our procedural regulations try to list all the different types of projects and state specific performance requirements that we think make sense in terms of different types of projects. This area of the regulations was amended a few years ago to address large multi-phased projects because we didn't have performance requirements that worked very well for those types of projects. But as we've actually used those over the years, we've encountered more problems. So what we're proposing here is a dramatic change in terms of just really stripping down and simplifying the whole process. What we're proposing is to really have one template for all projects. And essentially the way this would work is in the CON review itself, and when we approve a CON, we will have a very specific plan for implementing the project with timelines and steps. And then every CON we issue will basically have a shelf life of 12 months after it's issued. So you got to come back here within 12 months and provide us with a progress report that we can then compare to the implementation plan that you had when the CON was approved. And essentially, this will just be an annual requirement to extend your CON until the project is finished. We think this will be a lot less burdensome than what we've got now. We actually have quarterly reporting requirements now, so this will be one annual report. Realistically, the value of these performance requirements is really at the front end. If someone isn't getting their act together and getting a project obligated and started in the first couple of years, maybe a little bit longer for some of the bigger hospital projects, then that's a problem. And that's when the commission really needs to address the problem. Once applicants get a project started, that's not to say there can't be problems along the way, but typically, once resources are committed and spending on a project, construction of a project begins, the performance requirements in this area of the regulations become less important. So we think this will just be a better approach, a simpler approach to monitoring performance and making sure that projects get done on time. And we won't have the problem that we have now, which is that we've over time developed this long list of very specific project categories and specific performance requirements that has really gotten to be unwieldy. And before I conclude here, I just want to touch on a couple of other areas that aren't included in the presentation summary. The Certificate of Need law, as originally conceived, in its scope covered closure of healthcare facilities, which is a fairly odd kind of regulation, I think. But what's happened over time is that the statute has clearly eliminated any requirements for CON review of hospital closures. But we now have a statute that actually, based on the advice of my counsel, actually is kind of contradictory in some areas. There are some areas of the statute that you would read and say, well, these other types of facilities, non-hospital facilities, there are still requirements to obtain a CON before those facilities can close. In other areas, it looks like there may not be. So one of the things that we're looking at is establishing in these procedural regulations, which do cover the scope of CON regulation, that closing healthcare facilities, any type of healthcare facilities, not just hospitals, is not something that requires one to come to the commission and get a certificate of need to close. We've always felt that that's a very difficult type of regulation to implement. It doesn't make a lot of sense. So that's another area that we're going to address here. There will be notice requirements, and depending on what type of facility it is and what sort of other facilities there are available in the area, there may also be informational hearing requirements associated with closing facilities. We have obviously a new bill that specifically deals with transitions of hospitals to non-inpatient care facilities that have a new set of requirements. But that's another area that I just wanted to mention. And then in the longer memo that provides you with more detailed information on some of these changes, there is another area that I'm not covering here, and that's because that's still a work in progress. One of the things that we wanted to address, if possible, in these procedural regulations was the situation where hospitals are proposing capital projects that only require a CON because of the size of the capital expenditure. So there's a capital expenditure threshold. If there's nothing else in the project that categorically requires a CON, but your project is above that threshold, that requires a CON, but there's an out for hospitals. That's related to the fact that we regulate rates for hospitals in Maryland, and that is called taking the pledge. So if you pledge basically that you're not going to come back to the Health Services Cost Review Commission and seek a rate increase, in today's context, an increase in your global budget revenue or your total patient revenue to help you pay for the capital cost of the project. And we do give you a little bit of a cushion there. You can You can seek $1.5 million over the life of the project, which for a hospital construction project is going to be 25 or 30 years of depreciation and paying off debt. But you're pledging that basically you're not gonna look for those sort of increases in your rates, that the normal updates and the normal types of factors in which budgets are adjusted over time, you're confident that that with this particular project and the way it's going to affect your revenue and your debt capacity, you can really afford to do this without that kind of change. What we've thought about trying to do is eliminate or basically tighten up the ability of hospitals to come in and seek CONs for those types of projects. So what we've had in recent years, and the new payment model may be changing this, it's a little early to tell yet, but we have had hospitals who've come in and said, well, yeah, I could take the pledge for this project, but I want to get a CON, because that way you punched your ticket to basically ask for rate adjustments in the future. And that's a problem, because a lot of times those are projects that we really don't have state health plan criteria and standards that speak to, the essential elements of those projects. They obviously impose, staff resource requirements on us to review these and for you to make a decision on them. And so what we talked about trying to do here is maybe set some criteria that say, look, if your project has, these kind of characteristics, they're smaller in nature, and in consultation with HSCRC, we can make a determination that, look, you've got the revenue capacity, the fiscal capacity, and you also have the debt capacity to really handle this project without these sort of rate adjustments. It would be nice if we had the ability to say, look, we're not going to docket those, take the pledge. We're advised that we probably don't have the authority under our current statute to make the kind of changes that we outlined in the longer memo. We're going to continue to talk about that, but that is one area that we may end up having to look for some statutory changes if we want to do that. I think it's an area where, with the new payment model, the idea of how we've done these pledge projects in the past and the way we've handled hospitals who want to get a CON, even though they don't see an immediate need for adjustments in rates. I think with the new payment model, I think it really cries out for rethinking how that process is handled. So with that, I'm done, and I'd be happy to answer any questions that you have.
Thank you, Paul. As you can see, Chairman Tanio had to leave. And I appreciate the work that you've done here. This is something that the Commission has expressed, urged attention to as we have gone through the experience of looking at CONs and really looking at the enormous expense on the other side of the applicant's expense in order to adhere to the accretion of these regulations over time. So thanks for taking a first crack at this. And I'm going to open it up now to commissioners for any questions. One, two, three. Commissioner Pollard, comment?
I'm concerned about the fungibility, if you will, of the pledge. It's the whole concept of this pledge seems to bother me. It sort of suggests that at some point we're not going to reevaluate the overall economic situation and the viability of GBR in general, and sort of keeping the institution open and running and adding the Grover Norquist pledge on top of it seems not to include the flexibility that's necessary in order to potentially keep it running. But I guess I'm trying to get a sense of, I didn't hear exactly what's your thought in trying to limit the pledge. Do you feel like they're using the pledge as a way of getting something approved that otherwise wouldn't be approved? it looks like we have to look at the overall financial viability of the proposal, absent their assessment of the pledge.
It's not something that comes from a motivation of trying to get something approved that wouldn't be approved. It's using this regulatory process, certificate of need, to provide yourself with some, assurance that if things don't go the way that you hope they're going to go, or that most reasonable people think it's going to go, you're going to have the ability to make a case before the Health Services Cost Review Commission that you need more revenue. And if that case involves, I need more revenue because I really have encumbered myself with these capital-related expenses because of this project I did, that you approved, that we approved, yes.
I think, didn't we just have the experience with Suburban Hospital that we approved a CON with a condition, several conditions, and one of those conditions was that Suburban Hospital would not go back to the Commission for rate review, which wasn't that, is that my recollection?
Wasn't there a condition on like the unused space? I thought they weren't supposed to build in like some unregulated space.
Well, there was that too, but I thought also the capital.
There were a number of conditions on that. There was not a condition that prohibited them from, for example, making a partial rate application to HSCRC to help them with the capital associated cost of that project. They did not project a rate increase or a revenue adjustment as a source of funds for the project. So they came to us and said, yes, here's a project that we want to do. It will obviously increase our depreciation and long-term interest expenses. But when we look at where we are in terms of what we project as our revenue picture in the future and our ability to handle this debt, we don't think, Suburban Hospital told us that they don't think that they're going to need a partial rate application or a capital-related adjustment. They think that with the adjustments that hospitals get every year in their revenue, based on market shifts, based on inflation, based on a number of other factors, that they can handle it.
Right, I remember all that.
The revenue is going to grow. Everyone projects that the revenue is going to grow in the future, and they're telling us right now that they're comfortable that the non-extraordinary types of revenue adjustments that they're likely to get in the future are going to work for them, and they won't have any extraordinary need for additional revenue adjustments. But we punch their ticket, so they have the ability to seek those if they want to.
To that same point, I agree that at some point you need to rethink the kind of the growth and where you're applying your even if the total pie is the same, kind of what you're doing with this. At the same time, I think we've seen any number of repeated programs where someone promises what I think of as budget neutrality, and then 5 years later says, oops, I guess I was wrong, and it's now twice as expensive. And so the notion of that you're held, if you're coming in and promising that you will do it in a budget neutral way, that you have a strong incentive to keep that. That seems to me just smart policy to avoid being gamed by bad actors. I had a question in the more detailed document. So you go ahead and there's a number of points, and you sort of, on this idea of who has standing and kind of who is affected. And I applaud it in general because I think it's more competitive, it's more open. But then sort of you took some steps in that direction, but then there was a number of places where it used to say would, it would happen, but now it says could happen. And that seemed perhaps going back in the other direction a little bit. And I just wanted to know what your thinking was when you made those changes.
I think the way you just put that kind of expresses our thinking. We looked at those woods, and I think there were 2 of those, and we said, well, are we actually implementing this as it's written now? I mean, because can you demonstrate that absolutely this is going to have this certain effect on you? And so I think we did kind of rebalance there. We tightened up, the adverse effect definition, but then we also said probably these woods should be coulds, because we think realistically you're going to be coming in and trying to make to the staff or a reviewer, well, it's going to be to a reviewer in the case of an interested party, a case that, I'm in a position because of who I am, where I am, and the services I provide, that this could have this adverse impact on me. But I think we felt like saying would is putting a burden that's probably unrealistic. And to your other point too, and kind of backtrack a little bit, I want people to understand on this issue of the pledge and other things and the new payment model, these global budget revenues and total patient revenues, basically different types of global budgeting as kind of the main structure for rate regulation. These are budgets that include revenue for what HSCRC would typically refer to as routine capital expenditures. So, these are not operating budgets. They also are intended to provide hospitals with revenue that they will use to replace equipment, replace facilities that need to be replaced. And so I think, we've been gradually moving in the direction of really looking at how do we really focus on the big projects that a hospital really probably needs to rethink its whole kind of revenue structure to do, not a $20, $30, $40 million project. And we've seen those. We've seen those come in for CONs. They're expanding their ED. They're building a new cancer center. And those are examples of the kind of projects that, in my mind, do we really want to kind of allow them to kind of use CON and take up our time to look at those? They're only coming through here because of the size of the expenditure. One of the things we could approach differently in this area is we could increase the capital expenditure threshold. That was established at $10 million a few years ago. It's indexed for inflation, so it's now up to around $12 million. But if you raise that, that also kind of takes away the ability of hospitals. In other words, raise that to a level where you think, hey, we're now talking about levels of expenditures for certainly most hospitals that they should be able to handle with the global budget revenue that they're getting and that is getting updated every year. But that would be a statutory change, definitely.
Thank you, Paul, for the presentation, and thank you for addressing what I consider one of the most important points, is that of the interested party. I would like to echo my colleague's point on the use of the word could. To me, that's a little too broad. I see counsel getting up, and let's see what she can tell us. She got halfway up as he spoke earlier, so let's see.
Okay, so what is being suggested is to get rid of the broad, if you provide the same service in the same jurisdiction, okay? And that leaves, and that covered a whole lot of people, okay? Made them interested parties if they sought interested party status and provided comments as required by the regs. So getting rid of that, leaving the would, it means that there's a burden of proof to would, which is a pretty heavy burden, okay? So so the reviewer may end up needing to take evidence, really delve deeply into to determine the wood. And then there should probably be commission review of that determination because it impacts the entire review. So there can be another level of review in that of the would. And so it's sort of changing the would to could is a compromise to some extent, and frankly a more streamlined way of getting rid of that first provision where it's just providing the same service in the same jurisdiction or same regional planning area, and leaving the one about adversely affected, the changing that takes care of those problems and will keep y'all from having to see, I would expect, a lot of motions to overturn a determination, say that someone isn't an interested party. So I think it's what needs to be done.
Right. I still, and my mind kind of works like yours on this. We come from similar backgrounds. And I was thinking burden of proof issues as well. It just seems to me that could is so broad that I anticipate problems on that side just from the point of having the same very broad, it's like tried cases. Expert witnesses are being asked questions and they say, well, anything's possible. Okay, to me, that's kind of what this is. Anything could. And that's my concern. And I'm wondering, isn't there some qualifying language or some standard that we can write in that would be easier than individually hearing every single case, but would make it more likely than not that we would lose some of these interested parties who, are definitely causing problems with some of these.
I think getting rid of the first provision just provides the same service in the same planning region used for purposes of certificate of need. We'll get rid of some. This is lessening those who could qualify as an interested party. I mean, it may not be as far as you want to go, but I think there's some downsides to making it would and getting rid of that first provision.
I understand, counsel. Thank you for your point of view on that.
Can I make a friendly amendment here or a friendly comment? Is there some way to put an adjective or something that makes it more than this sort of, is it substantially could, significantly could, something that would make it more than, I mean, just, it is the softness of could,
Okay, well, let me tell you the process.
Really, really could, right.
and as we're, working more on finishing draft amendments, and it'll really be more a draft replacement, we'll certainly consider how that can be done. But the process that the commission uses, which is something that a lot of state agencies don't do, and it's a really wonderful process that goes beyond the requirements of Maryland law. They're draft regulations that are first released for informal public comment. Then everyone who wants to comments on the regs. Then the staff analyzes those comments and makes recommendations to the full commission on how to respond on what should be done as a result of, if anything, should be done as a result of those comments. Then at that point, the staff will present, amended draft regulations that will ask the commission to adopt its proposed permanent regulations. Then they're published in the register. Then there's the formal public comment process. And if there are no substantive changes that result from those formal comments, then the regs that were adopted as proposed can be adopted as final. If there are substantive changes, then you go back to square one, and then you go through adopting them as proposed again, and then the formal comment period, then going final. So going through the informal comment period really allows the commission to have better regulations and actually a shorter overall time period than if you did something you needed to make a change and you had to go back to square one. So there's going to be time for comments and then additional suggestions.
Yes, thank you, Saul. And so I think what we've added here is that even before we begin that, we're sort of giving you a preview, and certain, whether adjectives or whatever needs to be added, we'll certainly take that into consideration as we even begin this very formal process with that leads to regs down the future, but we haven't yet informally engaged stakeholders. That's the important thing. We're bringing this to you all even before we've engaged informally stakeholders, but this guidance is very helpful.
Commissioner?
Hi. I just want to ask if possible, not for now, it could take it offline, have a definition of what community support means, and specifically to the viability of the proposal.
I'd like to weigh in on the great would-could debate of 2016.
It's only just eating up.
Well, it's just this, that when we're streamlining, if we're going to streamline, that sometimes it's actually more efficient to just let people have their say than to fight a lot about whether they should or shouldn't have spoken. And defining these standards too tightly in a way that can be litigated could very easily tie us up into, especially on anything important. Yeah. We could be sitting here debating would or could they do it or not, on a lot of big cases where people have a lot of incentive to hire lawyers to find. Let's knock them out as a party, and then we won't have to deal with their very good arguments about why our project is bad, right? Which is what you would have paid me to do when I was in private practice. It would have been expensive, and the other side would have to get their lawyers, and you would have to hear all of my 15 reasons. Whereas it might be more efficient to just, in many cases, hear people that have reasonable interest, hear what they have to say, and reject it if it's not any good.
Thank you.
Just a quick question. I might have missed this before, but what's the definition of a contiguous planning region? Can you give me an example?
A contiguous planning region to planning region A would be a region that shares a border that's
a border. I mean, a region is not a border. I mean, I'll give you a specific question. Say Shore Regional wants to build a hospital in Upper Talbot County. Does Kent County have any interested party status there? We have a hospital in our county.
Well, if Kent
County it doesn't border exactly Talbot County, but it's in a contiguous region, I would think.
Well, if let's say Kent, Caroline, and Queen Anne's.
Right.
May not make any.
It used to be Kent and Queen Anne Hospital, by the way. So.
Kent, Queen Anne's, and Caroline were defined as a region, and Talbot and Dorchester were defined as a separate region.
So the answer is we would have
those two regions would be contiguous.
Okay.
Certainly.
Thank you.
Any other questions of Paul or comments?
The pledge, back to that, that's nothing in regulation, right? That's just the commission with the pledge?
It's in statute and regulation.
It is in statute?
They don't call it the pledge, but...
That's the word we call it, but yeah.
It would seem to me that if a large hospital system pledged, 4 or 5 years down the road, they were having financial difficulties, I can't see the HSCRC saying, no, you're going to just go under. I don't know how good the pledge, what it really means.
It's not more powerful than politics.
Oh. So with that, I think we'll thank Paul for taking this first step. The next time we will take this up will be.
So we're going to take the time to do one more big push, go through all this again. I think we'll find some other things. We'll certainly take the comments we had here into account, and then we'll start the process of informal review before we bring this as a proposed regulation to the
Well, thank you very much for working on this. As anyone that's had the experience of being a reviewer in a complicated case with a lot of interested parties will truly appreciate the work that Paul and his team are doing. Thank you, Paul. Okay, moving on to our last agenda item. Presentation, Maryland Patient Safety Center. This is a presentation of the strategic plan. So by way of background, let me just introduce the topic and the center itself. In July 2015, the MHCC established an agreement redesignating the Maryland Patient Safety Center Incorporated as the Maryland Patient Safety Center. In addition to redesignating MPSC Incorporated, the agreement required the center to submit progress reports and present a strategic plan for the upcoming fiscal year. Robert Imhoff, President and CEO of the Maryland Patient Safety Center, with his colleague who he will introduce, will provide the center's progress and present the fiscal year 2017 program plan. Before he begins, Tressa Lee, Director of Quality Measurement and Reporting, will give some introductory remarks.
Thank you, Commissioner Phillips. Good afternoon, Commissioners. Actually, I just had some brief remarks, and you basically gave those remarks in your overview. So in the interest of time, I will just move to introduce Robert Imhoff, President and CEO of the Maryland Patient Safety Center.
Thank you. It's a pleasure to be here to give our annual update. I'm joined today by our Director of Operations, Bonnie DePietro. Bonnie has been with the center just almost 4 years. She started 6 months after I did, so we have taken this journey of revamping the organization together. Let me start first with our listing of Board of Directors. Since I was here last year, we've had 5 changes. That includes Deborah Dockin. Deborah is a patient family advocate. Deborah serves on the Patient Advisory Board of Sibley Hospital, one of the Johns Hopkins hospitals. We also have Paul Fronston, who was a former member of the Commission, was the designee for the Maryland Healthcare Commission, still serving on the board. Delegate Cherie Sample Hughes is our representative from the House or the General Assembly. Sue Sheridan, who is affiliated with PCORI and is also a nationally known patient family-centered care advocate. And then Barbara Tchaikovsky. Barbara was former CEO of Mainline Hospitals in Paoli, Pennsylvania, has retired to Baltimore and has become involved with the Maryland Patient Safety Center. There are 4 committees of the board. They include strategic planning, patient and family-centered care. We have a nominating committee and an executive committee. I will characterize the board as very active and participatory. Each board meeting includes a strategic discussion around an applicable topic or area of interest to the center. Next slide is our strategic priorities, which you have seen before. I will tell you we are in the process of revamping this dashboard. Part of the charge of the Strategic Planning Committee is to update this, update our strategic plan, our strategic direction. We've been working on this for about 6 months. We had hoped to have something by the end of the fiscal year, which is this month. However, that's been pushed back probably until September. One of the things that we will be including in this is a more addition of consumer-focused or centered around the patient and family-centered care issues. So more to come on this. Our strategic partners, I will not, for the sake of time, I'll just let you read. I won't go over each one, but we have, I feel, a very provider diverse group helping us with our different initiatives, including the Surgical Center Association, Health Facilities Association of Maryland, which represents a good portion of the long-term care community. Then our partners such as VHQC, I feel we've established a very strong relationship with them. Bonnie, when she talks about our program, will talk about some of our partnership opportunities there. The Lifespan Network, which represents the nonprofit end of the long-term care community, just to name a few. And please stop me if there are questions about this as I go on. Our next slide are fiscal 16 highlights. As I mentioned, our fiscal year ends June 30 of this year. We began marketing our Caring for the Caregiver program. For those of you who are unfamiliar, the Caring for the Caregiver program is a cooperative program we started with the Johns Hopkins Armstrong Institute that addresses the second victim situation. We had identified this program as one of our fee-for-service programs, not only to advance patient safety, there are very strong patient safety implications with this, but to also as a source of revenue for the center as we become less dependent on HSCRC funding. We have member hospitals, which we classify as dues paying, those who will write a check once a year to the hospital. A couple of years ago, we changed our model from a contribution-based organization to a member-based organization. We were accepting voluntary contributions from the hospitals, and then they would pay a fee for each service that they access, such as the conference or our educational sessions or whatnot. We changed this around a couple of years ago to have them paying an annual membership fee, which would include most of our programming and then significant discounts on the other activities of the center. Mid-Atlantic Patient Safety Organization is our official federally listed patient safety organization. We changed this around about a year ago and had our official patient safety activities come under a component organization. We worked on this with AHRQ when they did our compliance audit then. We now have 26 facilities, including two long-term care facilities, and 24 hospitals. Those are organizations that have actually signed the dotted line and said, we will participate in your federally listed patient safety organization. That allows them to access our official, and pardon me for keep saying that, but there is a delineation, our official patient safety organization activities, such as safe tables, and when we institute our adverse event reporting. So there obviously is overlap between the two, the paying dues, and then there is exclusivity between the Mid-Atlantic PSO and then the member organizations. We are under our perinatal neonatal quality initiative. We commenced the first time C-section initiative and also the neonatal abstinence syndrome initiative, which Bonnie will talk about in detail in just a moment. Typo here, we recruited 19 hospitals, 4 long-term care facilities, and 5 ambulatory surgical centers for our Clean Collaborative initiative, and we continue to recruit for that initiative. Our Sepsis Collaborative, 2 cohorts, cohort 1, is comprised of 10 acute care hospitals within the state of Maryland. Cohort 2 is 11 hospitals. They were staggered in their commencement. Bonnie, again, we'll get into detail, but we're showing very positive results. Decreased sepsis mortality, 11 and 11.1% respectively. We have partnered with VHQC in a sepsis initiative that involves long-term care. Currently, there are 32 long-term care facilities involved in that program. That is in the infancy stages. We ended our Safe from Falls Collaborative after several years working with 21 long-term care facilities. We changed kind of midstream the measurement from just the rate of falls to rate of falls with injury, and we have seen or saw a substantial decrease in that measurement with those facilities. Which brings us to fiscal 17 and our initiatives. I'm going to turn things over to Bonnie and let her discuss in detail what we're doing and what's happening in that regard.
So we have 2 perinatal neonatal quality collaboratives that we're working on for fiscal 17 and into fiscal 18. The first one is reducing the rate of primary C-sections. Studies show that once a woman has her first
C-section. Subsequent pregnancies are 90% more likely to be C-sections as well. So we have partnered up with the Alliance for Innovation in Maternal Health, otherwise known as AIM, to work on rolling out a bundle that AIM developed. AIM is a group of about 6 organizations such as ACOG, AWAN, the Nurse Midwife Association, lots of really good organizations got together and collaborated on some best practice guidelines. We have 31 of our 32 birthing hospitals in Maryland have signed up to participate in that initiative, so we're real happy with the participation rate. Right now they are collecting their first quarterly data, which will be due to be reported in July. The metrics that we're looking for this are specifically the rate of C-sections among first-time, term, single birth, head-down delivery. So it's a very finite population, otherwise normal pregnancy, just looking at those cases that result in a C-section and then drilling down to why. So we will be able to get that data, preliminary data, from vital statistics off the birth certificate record so that we can do some rapid cycle quality improvement by hospital, and then some process and structure measures with those hospitals and those teams in terms of what they're doing to look at those. So we don't have any data on that yet. We've just kicked that off. The second one is looking at neonatal abstinence syndrome practices within our birthing hospitals as well. We are recruiting right now into that particular collaborative. We have partnered with an organization called the Vermont Oxford Network, which is an organization that focuses in on perinatal neonatal initiatives, has incredible resources, has done a number of projects, and has developed some e-modules and a toolkit that we will be able to give access to all of our participating hospitals. So we're in the recruitment phase for that. I can say as of yesterday we have our first one, but we have a lot of interest and a lot of commitment. What we'll be looking at doing is we won't mandate order sets to them, but we're going to provide them with best practices. The care of these infants is all over the place, and our goals are to decrease length of stay, decrease readmissions. Sometimes they're discharged home in withdrawal and have to come back and be readmitted because nobody was even aware that mom was using any drugs, and decreased transfers to higher levels of care. So those are the 3 metrics that we'll be looking at. Stopping sepsis is the VHQC, our QIO partner, that is looking at 32 Maryland long-term care facilities. Sepsis rates, we'll be able to see the numbers of admissions to their local hospital with sepsis, and we're a partner with them, consulting with them, providing some consultation to them. Improving sepsis survival is our acute care sepsis project. Like Robert mentioned, we have 2 cohorts. Cohort 1 is ending in this month. Cohort 2 with 11 hospitals ends next year, and we are seeing positive results in the numbers of sepsis mortality. So we have 21 there. The CLEAN Collaborative, we just kicked off. We had our kickoff session on March the 9th. This is a collaborative to improve cleaning and disinfection of surface contamination in facilities. We have participants in acute care, long-term care, and ambulatory surgery. We are just now collecting May data. It's at our first data set, so I don't have numbers for you, but there's a lot of excitement around that. So we have a total of 28 participants in that. Coming up, what we're going to do in fiscal 17 is develop some study groups or focus groups on these next 3 topics: errors in diagnosis, patient family-centered care bundle, and medication reconciliation. These are projects that we are interested in, our board was interested in working on, but we want to convene an interested group of experts and interested parties to determine exactly what should we do and talk about, do we do a collaborative on these. Errors in diagnosis, there was a recent report from the IOM. That's kind of out there, but it's so big that, you know, do we just focus on a segment? Do we just look at diagnostic errors in radiology? It's huge. So what do we want to do with that? So that's what we'll be doing in fiscal 17 with those three topics, is either developing a collaborative, developing, you know, educational modules, or something along that line.
Moving on to fiscal 17 educational programs, we will continue with our normal slate of programming, such as failure mode effect analysis, root cause analysis, team steps, human factors. We will also be adding an appreciative inquiry class, which is part of our certification program and has garnered a lot of attention over the last several months, this concept of appreciative inquiry on how to address problems and challenges within an organization. Our conferences will remain also as part of our educational offerings. We have 2 conferences each year. We have a very large regional patient safety conference in the spring. Last year we attracted about 1,200 attendees to this one-day conference. We also award patient safety awards. We received over 75 submissions last year for work that the hospitals and long-term care facilities are doing around patient safety. We have an independent panel that scores and judges those, and we make those awards at the conference. In the fall, late fall, early winter, we have a medication safety conference. This year it will be held early November and will be focused on the opioid situation. The next slides are graphic representation of the program, the sepsis program, and also the Safe from Falls. So I'll let Bonnie go through that, and we'll certainly, or then entertain your questions regarding the presentation.
So the first graph you see there was our Safe from Falls long-term care. Falls was an initiative that Maryland Patient Safety Center looked at for a number of years, and it was being measured in acute care, long-term care, and home health. In July of 2014, we let go or ended the collaborative for acute care and for home health because of the significant gains we had seen, but we wanted to focus more energy on long-term care. So we recruited 21 long-term care facilities. We monitored their rate of falls, which still stayed pretty flat, which we had been seeing for a number of years, and really focused in on falls with injury and preventing harm. So this is the outcome of that collaborative, which was an 18-month collaborative involving those 21 hospitals. We had one dropout at the end, if you see the end there. We had great participation once we got going, and then one had some turnover in leadership and withdrew from the project. Improving sepsis survival, the first graph you see is what cohort 1 has been doing. We tend to report without that first month, we think, for both cohorts. The first month, they are looking at 2 particular ICD-10 codes in this, severe sepsis and septic shock. So we are looking at that as a primary or secondary diagnosis only. They're pulling only those cases and looking at mortality of those cases. So the cohort 1 started out really low, but we think that was aberrant. So, but they're trending really well.
Clarification. So most recently, March 2016, this suggests that 21.43% of those in participating hospitals with a diagnosis of sepsis died?
Severe sepsis or septic shock died, yes.
So that's what's on the y-axis. The percentages is the percent
yes.
of individuals in those participating hospitals
yes.
with those 2 diagnoses
yes.
died during that admission.
Got it. Yes. Thank you. Now, to compare that to the state rate, this is on everybody's radar. The reason we are looking at this is because the rate of people that die from these ICD-10 codes, that die with these ICD-10 codes, is also up around 27, has been as high as 30%. So we're tracking how our cohorts are comparing with the state rate. We've lost some, prior to the conversion from ICD-9s to ICD-10s, we were running significantly under by about 5 to 8%. With the conversion to the ICD-10, we have not been able to get data that looks correct from HSCRC on this.
Are these admission diagnoses, discharge diagnoses?
Discharge.
Are there criteria for septic shock, or is this the ER doc making this diagnosis, or the hospitalist making this diagnosis, or?
The diagnosis is made by coding, by what's in the record. So it depends on who's documenting.
So it's a coder who puts together a bunch of different ICD numbers and comes out with septic.
The coder codes it with ICD-10 codes, yes. So is there an issue with coding at some facilities?
That's what I'm trying to make. Is there a variability there?
Absolutely. So coder education is part of some of the work that goes on, but that's what we're reporting on, is the coding of the case. So the next graph, yeah. Oh, I'm sorry.
On these cohort 1 and cohort 2, quite a bit of noise, but among the 10 participants, how much variability is in the individual hospitals? I mean, is this variability that we see in aggregate also showing up among the 10 facilities? Does it track, or are there outliers on these results that are both positive and negative that are causing these pivot points?
Yeah, the variability in the participants was big. In cohort 1, we had different levels of maturity of the sepsis teams in the hospitals. So this particular initiative was a bit different than any we've ever done. One, we limited the number of participants because we wanted to provide a high level of individual consultation with these teams. So we had, for example, in cohort 1, a team or a hospital that didn't even have a sepsis team, that didn't think they had a problem with sepsis. But their CEO, I said, then why are you here? And their CEO said they had to come and participate. But that hospital didn't feel they had an issue. The reason they didn't have an issue is they were transferring everybody to a higher level hospital when they started crashing. That's why. That to another hospital in that group that had a sepsis team in place and had been working on this for 7 years. So the variability in the facilities was very broad, and the variability in terms of their mortality wasn't super wide, in my opinion, but there were some that were doing better. The other thing we did in this is that we removed all confidentiality among the team. So we said to them, you have to agree to be able to share your percent results, not your number of cases, but your percent results with each other, so that we could build this and force this collaboration that we wanted to happen. So it's been, as a clinician, for me, a wonderful experience to be working with these groups and the level of collaboration that alone built in, not to mention the spirit that we all have to improve for the waiver, not just one. We're not competing. We're all in this together to improve healthcare for Maryland. So that's the tone. We also did not dictate to them that they had to implement any of the Surviving Sepsis campaign. We did not dictate order sets to them. We said it's probably a good idea to have some, to help you standardize your care, and they've been proved to be effective. We didn't dictate to them what metrics they had to monitor, but we provided them. You know, here's the 3-hour bundle things you should do, because one of the things in impacting sepsis is early identification. So we are only looking at the outcome in this particular collaborative, and but encouraging other practices. But not every hospital was ready to take it on at the same place. So we really individualized the work we were doing with each hospital and each team.
Are your mortality rates based on discharge weighted or hospital weighted rates?
No.
They're hospital weighted?
No.
So each hospital counts one.
Each hospital is reporting their own rates. But what do you mean by weighted?
So are you weighting, are your overall statewide or your cohort-based rates based on the number of patients within each hospital, or is each hospital contributing its weight to the overall cohort weight?
We took the total number of cases reported by each for each hospital, total number of deaths in those 2 ICD-10s, total number of, we're only looking at 2 ICD-10 codes.
Right.
So those total number, the mortality on top of that, total number of all that was reported.
So
it's not an average it's It's total cases.
Okay, yeah, we'll talk offline. I don't think
Okay.
I quite understand.
Cohort 2, just a comment, started doing much better, much faster, and we do believe CMS implemented a core measure in October, and we think that, although we'd like to say it's our work, we think that that had a significant impact on Cohort 2. I do have the state data that we have through what we have, but we're missing quite a bit. We're missing data since October. Was there another question?
Yeah, it relates to the diagnosis of sepsis over time. So it's diagnosis by the coders of sepsis over time, and I apologize, I stepped out and if this has already been discussed, but this gets to this bias that I've expressed before as to what happens when you change the reporting criteria over time. The rates of sepsis death are markedly decreased. And one way to do that is by decreasing the number of cases, is by tightening up your definition of sepsis or changing your definition of sepsis. And if the incentive is to do that, how do you know that the coders, what quality assurance have you gone back with to assure that the percentage of cases of sepsis within the hospital are staying the same relative to the adjusted case mix?
Well, the quick answer is nothing, because it's not something I can control. We know that coding, the better educated the coders are, the better the numbers are. So in talking with other individuals that have run sepsis collaboratives, a big component is working with coders. But we haven't seen any hospital have some marked change with coder education.
30% change in the sepsis mortality rate is massive. A massive change. I mean, that's the first thing that comes to mind, is that has to be a piece of it.
I'm sure it is, but
Are
I
we
don't
killing
know.
that many people before, or are we just changing the way that we're calculating?
Yeah.
Yeah, wouldn't it be more accurate to study one hospital's rates and see the variability between different hospitals and see if they're using the same criteria to code for septic shock?
Well, we gave them the criteria. They've all received the criteria, but we could go back and look at a particular hospital.
The coders are doing it, you mean? They meaning, when you say they, the coders?
The teams. The hospital teams were given the criteria. Yeah.
But you could, I mean, if you had the budget, et cetera, but you could audit, you could just pull those cases, recode them by a neutral third party, and see how they lined up.
Right, so I think the point is that these are self-reported by the hospitals.
Yeah, that is an important focus. It's a self-reporting.
You're reporting what they report.
And we are working, I mean, we do want to look at what
the state sees.
Just to point out the conflicts, you're grading them now. You're grading the hospitals on their mortality rate from sepsis.
Yeah.
And previously, you were rewarding them for diagnosing sepsis. So you've changed those criteria at the same time. You got to balance that.
That's just like we weren't giving enough pain medicine 20 years ago. Now we're the cause of drug addiction, giving too much pain medicine.
Robert, do you want to finish up, or are you?
Yeah, just the last two slides list the members, again, dues-paying members, and then the members of the Mid-Atlantic Patient Safety Organization. So that concludes the presentation.
Other questions? Yeah, we'll go around.
Yes.
Yeah.
In our last monthly meeting, we were presented with some CDC figures about hospital-acquired infections that were depressing, should I say? Is that sort of the group? I mean, that Maryland was like, what, the worst in the country, or, you know, somewhere just ahead of Mississippi or something. I mean, they were just very, very disturbing numbers. And I didn't hear of the various things that you're on your list of initiatives and whatnot, whether hospital-acquired infections. I just didn't hear that. And given these compelling CDC numbers, I'd like to encourage you to consider that one, because it just seems like Maryland has badly dropped the ball on that particular, at least according to CDC.
We started this journey years ago, and Commissioner Phillips knows what I'm speaking of, with the hand hygiene initiative, which was started back in 2010. We concluded that 18 months ago.
December of 20.
18 months ago. We raised compliance rate, overall state compliance rate, 44 of the 45 acute care hospitals participating, from 72% to over 90%. We hit a high of 94%. The collaborative was concluded. However, the hospitals, the participating hospitals, still collect data, and they still report it. MHA now collects the data just to make sure that these continue to be hardwired. And we're seeing still 90+% every month compliance rate. So as a progression from that, and we did see a corresponding, as compliance increased, we saw a corresponding decrease in HAIs. So to work on that success, we established the CLEAN Collaborative, which has to do with surface contamination, which is a CDC priority, or the surface contamination is. So even before that 2014 data, we saw that, I think 2 or 3 months ago that came out. Even before we had started the CLEAN Collaborative, we're developing that program, again, toward reducing HAI. So that's our initiative in that regard. What we're looking at is reducing levels of C. diff, VRE, and MRSA. So we do have, to the extent that we are able within the confines of our budget and human capital and whatnot, we are doing something in that regard.
Yeah, thank you very much for the presentation. Mr. Imhoff, I noticed on the first page, your mission is why we exist, to make healthcare in Maryland the safest in the nation. That's a tall order. As my colleague, Commissioner O'Grady, pointed out, we got some very bad news a month ago about our performance. And I've talked with staff, and they have indicated that, in fact, despite the fact that Maryland has an outstanding reputation for hospitals and the delivery of health care and the ratio of doctors to patients, and one would think, Maryland up there with Massachusetts and Connecticut, relatively wealthy state, that actually we have not historically done as well as we should. When you say making healthcare in Maryland the safest in the nation, do you have an idea what state is the safest in the nation right now for healthcare? Do you have any idea?
It depends, and one of the issues that we have, one of the issues taken up as far as revamping that document, is what does safest in the nation mean?
Right. By
what measure, by what metric do you say that? I mean, I think tall would be understatement of what that statement is. That was the strategic plan adopted about 6 years ago, and we've had a lot of discussion at the board level about what that means. And quite frankly, people are not comfortable with it because it does not define what the safest in the nation is. Does that mean C. diff rates? Does that mean HAIs? Does it mean sepsis rates? Whatever, falls. I mean, there are a number of different things, a myriad of things that you could measure that by. So I can't tell you what the safest state is because it would depend on what measure you want to go by.
Right.
The second piece of that is it is something we have identified we feel is far too ambiguous as far as a statement, and it's one of the things that the Strategic Planning Committee of the board and the board are working on to clean up, I guess, lack of better terms, to make it more understandable and more attainable.
Well, I must tell you, I wish you the best of luck in doing this because the Maryland Healthcare Commission, one of our duties is to make sure that we provide the highest quality health care. We take whatever initiatives are, whether they're regulatory steps or public education steps, to try to actually do that, to actually improve the quality of healthcare delivery and at the same time improve safety. We've had some success, but as Commissioner O'Grady pointed out, we've got, I think, a long way to go. We have to figure out, I think this is going to be our job at some point, we're going to have to figure out what the standards actually will be. And they have to be comparable with the standards that are adopted in other states. Maybe we use a federal standard, CDC, or maybe we should use the Leapfrog group. I'm not really clear about this. I think the staff is going to have to give us good input on exactly how to do that. But it seems to me, in any event, this is a huge responsibility for us, and we want your help on this, if you can give it to us, because I think we have a long way to go based on previous presentations to this commission.
Not only do we welcome that, and I agree with all of your statements, but we look forward to your help also.
Thank you.
If I could, were you here to speak?
I'll be brief because I know we're way over time anyway. I'm just adding on to this thing. But what you just described is the Achilles heel of the entire process of measuring quality and safety anywhere. Nobody has good measures of it. Nobody knows exactly what it is. And we can't get reproducible measures. And the ones that we do use, I keep picking on like this as highly flawed and not sufficiently granular yet yet broad enough to answer any questions about process. The idea of getting good quality metrics and good performance measures that we can use across a series of diagnoses and problems is one that has to be addressed at a federal level. There has to be enough funding put together to establish the data to be able to do this so that we're doing more than just process measuring. Hand hygiene is way too off to be able to measure as even its effectiveness in the hospitals. Yes, we're improving. Yes, hand hygiene is improving. I'm not sure those things are at all related to one another. And yes, it's important to wash your hands. Those things are all related.
But I would say to you, Commissioner, one of the problems we have at the federal level is the fact that what we are engaged in right now, pursuant to federal law, with MACRA, is to try to develop quality measures for the payment of physicians.
But
and
MACRA
it's not working.
It directs that process to the associations. It really does give them the ability to develop, the cardiologists to develop specific performance measures and quality metrics for the cardiologists, the orthopedic surgeons for the orthopedic surgeons, the general surgeons for the general surgeons. We just need to fund that process nationally, get enough, and it's expensive to do that. And some groups are ahead of others, but we're not there yet. We're probably still 10 years away from having good measures to be able to do what you said, which is define who's the best in the country at safety and quality. And we're never going to get that number. We're going to get it by diagnosis and specialty.
Well, the Commission doesn't have 10 years to wait for the federal government to actually establish a uniform standard. And I, frankly, have had enough experience with the Centers for Medicare and Medicaid Services to know that it is a bad idea to wait for them to do much of anything.
They're not going to do it. That was exactly the process, is getting it out of their hands and getting it at least into the hands of the docs.
Just echo with Dr. Pollack. I believe the reporting variability is too extensive to measure. In our facility, and I'm sure in most facilities, it's nurses who do reporting of infectious problems. And I can tell you personally that some things reported as infections are not. For instance, they swab
the exit side of a G tube and it gets reported as an infection. It's not. Urine comes back, multiple organisms, or they get a urine analysis of a patient with an ileal loop. No symptoms, nothing going on. It's not an infection. It's all colonized. It gets reported as infection. So I'm saying, unless you have an infectious disease monitor, doctor, measuring true infections, I don't think you'll ever get an accurate reporting of infections.
So a couple observations that, the results you have, I mean, what, I think that's, interesting, perhaps even impressive, but what are the targets? I mean, do some of these initiatives, do you set goals for the participants? And two, are these hospitals that are clustered in the Baltimore metro area or the Baltimore, Washington metro areas? And, are there efforts to engage, hospitals more broadly across the state, including some of our more rural hospitals?
Are you speaking specifically of sepsis?
Well, that's what I'm looking at right now.
So for this process, we sent out, we tried to recruit, or we offered participation in this program to all acute care hospitals. So we did not target the Baltimore metropolitan area. We did not target the Washington, D.C. suburbs. It was everyone. We received 34 completed applications to participate in this. 21 ended up participating for a number of different reasons. Some wanted to, ended up not wanting to, turnover, all kind of things happen. Bonnie can tell you specifically about who's involved, what kind of geographic concentration there is, but the intent is to get, for all of our collaboratives, the intent initiatives is to get as broad base and as wide a representation statewide as possible. We would like to have, we have these 19 hospitals for the Clean Collaborative. We'd like to have 45 hospitals. We obviously can't mandate participation. It's voluntary. We understand that the hospitals are under a lot of pressure with lots of other things, data collection initiatives and whatnot. So we sometimes are at the bottom rung of the ladder for participation, and we're happy for those that do it. I think, in a lot of respects, we do very well with who's involved, and I think the neonatal, perinatal collaboratives are representative of that. But we always want more. We always want as broad-based as possible, and I'll let Bonnie speak to what specifically.
I think we're about to run out of time. Unless there's anyone else that has some burning question or comment. Tressa has something to say, and it's burning.
We will be back next month with cervical site infections and CAUTI, and we'll try to give a very concise overview of these issues that make it difficult to say.
That includes the Maryland Patient Safety Center when you say we?
Oh, I'm sorry, the staff. Actually, Eileen and I will be back.
Good.
Yep.
We'll look forward to that.
Okay.
I would like to say that I had some questions. In the interest of time, I'm going to hold them. I also have questions from Commissioner Stollenwerk, who asked me to ask on her behalf, and I will not do that because we're running out of time. What I will do is ask staff here to convey those questions to you, CC other commissioners, and if you would kindly respond back to us. We can do that by way of email.
We'd be delighted to.
Yeah, great. I think it's really important. It touches to the heart of what our commission takes really seriously, including the transparency to the extent that that's possible for consumers. So with that, thank you very much.
Thank you.
We look forward to seeing you, if not a year from now, for your annual review. We get quarterly, or is it quarterly? Semi-annual reports.
December and this time of year.
Okay, great. Thank you both for holding in here. Okay, with that, we're going to pivot to Ben, correct? Yes.
Yes, so for updates for next month, first off, one point we overlooked at the start was to announce that there's been some ongoing discussion in terms of collaboration with HSCRC. The new chair of HSCRC, Nelson Sabatini, talked with Craig, Dr. Tanio last month, requested that we provide a recommendation on a commissioner who could serve ex officio on the HSCRC. That's our Vice Chair, Commissioner Phillips. She will begin doing that, I think, in July. At the next meeting, we'll discuss whether we want to establish a parallel relationship with HSCRC, have one of their commissioners attend ex officio here. We do seem to have one chair or two chairs extra, but they have only 7 commissioners, unlike the 15 that we have, so we'll have to be sure to be flexible about how they would do that. We will be getting all commissioner input on that before we move forward, and we'll try to do that in the next meeting. I will likely be sending out a communication to you all regarding that process and how the chairs would like to move forward. Next month, we'll have the long-awaited IRB for the University of Maryland School of Public Health appears to be nearing completion, so they will come before, we'll have a data release action item. We'll also have, as Teresa already said, some additional releases from the Healthcare Quality Reporting website. Hopefully before Dr. Bob left, we confirmed that he is routinely looking at that quality site. There's more updated information on hospital-acquired infections and other information beyond 2014. We also expect to have a couple of CON action items. These are not large CONs, but we're moving through that process. And then lastly, we'll have 2 regulatory actions. First, the organ transplant chapter. You heard Eileen Fleck present the public comments back to you in May. We're ready to take the regulations forward for proposed final action at this July meeting. We'll also we're aiming to bring forward the freestanding medical facility regulations. As I mentioned, there will be a meeting on June 22nd to consider the changes to the draft plan chapter that will incorporate the provisions related to conversion, that if we can get consensus, we'd like to bring those forward in July so they can be moved through the regulatory process. And I'll keep you posted on the status of those going forward. I know the legislative leadership thought in parallel with the work group, appreciate everyone's frank comments. So we needed to move forward on regulations in this area as well. So lastly, in terms of the reworking the administrative procedure regs, we're going to continue to work forward on that and look for some way forward on some of the capital threshold requirements, which may include making statutory changes. Thank you very much for your diligence today, and look forward to seeing you next month.
Second. Any opposed? Thank you all. Next month. For the new commissioners, it doesn't usually last this long, right? This would be close to a record.
Part of my fault. I will have the annual initiative insurance. What would I have to do now?
Yeah, this one I